That's really great, sir. Thank you so much for blessing us, sir.
Dr. Sunita, welcome.
Hi, Sunita ma'am.
Hi, Shanti madam. Hi. Hi, Paili sir. Hi, Jaya.
Hi, ma'am. Looking
Hi,
gorgeous,
hi,
as
Rajashree ma'am.
usual.
Hi, Preeti.
Welcome.
Hello, Sunita ji. Hello.
Hi, hi.
Pramila ma'am, welcome.
I am in.
Hello, Pramila ma'am. Welcome, ma'am. Pramila ma'am, thank you for accepting our invite and thank you so much for joining us.
So, Jai Rani, if my lecture doesn't start here, I can have a lecture here. Okay.
No, sir, yeah, finishing, you'll have an, ma'am, I'll put it at the last one. So after the panel, you can come and join us.
No, probably we are starting my talk here at 8 o'clock. So I might as well finish and then join here.
That's not
We'll
a
see
problem.
after Dr. Paili's talk.
Yeah, sure. We'll have it.
Thank
Not a
you.
problem. Yeah,
Thank
sure. Thank you, ma'am.
Ma'am, shall we start, ma'am?
Yeah, please, Chitra.
Okay.
Yeah, ma'am.
Okay.
Good evening, doctors. Welcome to the OGSSI Safe Motherhood Committee webinar. I will introduce our MOC of the show, Dr. S. Rajashree ma'am. Ma'am is executive member of OGSSI and ma'am is a chair of OGSSI Safe Motherhood Committee. I'm handing over to Rajashree ma'am.
Thank you, Chitrakala. A very pleasant evening to one and all. I'm happy to greet you all to the academic feast that awaits us. To commemorate the National Safe Motherhood Day, which is celebrated on April 11th every year, OGSSI Safe Motherhood Committee has organized this live webinar towards safe motherhood. The aim of today's deliberation is to raise awareness on the importance of providing safe and respectful maternity care, and also to highlight the significant strides that we have made in the field of maternal health over the years. From baby steps, we obstetricians have taken giant leaps to work tirelessly and put in concerted efforts with the government to reduce maternal mortality significantly in our country. To hear it all today, we have the stalwarts here, and I will not hold on. As is customary, we start this program with Tamil Thar Valthu. Can we have the Tamil Thar Valthu? The lighting of lamp signifies the renewal of darkness and the beginning of new phase. We'll have the lighting of lamp now. I now request our beloved and enthusiastic OGSSI President, Dr. Jairani Kamaraj, to deliver the welcome address.
Thank you, Rajashree. Anivarukkum vanakkam. Respected Chief Guest, Dr. Paili sir, Guest of Honor, Dr. Preeti, the Safe Motherhood Committee Chairperson, and the senior faculties, Dr. Sunita, Dr. and Sangeeta Menon, Madam, Dr. Pramila Menon, and Dr. Sudarshan and Dr. Shanti Gunasingh Madam and all the senior obstetricians all over the country. It has been a great pleasure and honor to welcome you one and all for this OGSSI Safe Motherhood Committee webinar, which is to mark the awareness about the safe motherhood, the goal of us, all of us working together to reduce the maternal mortality all over the country from every part of the world. So it is a great pride and honor for OGSSI to have this day with the stalwartcy and doyens of people who work for the reduction in the maternal mortality in the Indian population. And we have all the senior people here. And on behalf of OGSSI 23 team, I welcome all the seniors, all the guests, and all the delegates to this wonderful webinar. And a very special thanks to Sheil for sharing the platform, and welcome you one and all. Over to Dr. Kundavai for the OGSSI prayer.
Shall I? Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe, free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
So thank you, Kundavai. We are now moving on to the inauguration. I have the great pleasure, pride, honor, and very great emotion to welcome and introduce the chief guest for this webinar, Dr. Paili sir. Sir is known all over the world. He's a man who is known for all his eminent work in the field of OBGYN. He is the senior consultant and HOD of the OBGYN department. His special interest, we all know, is the high-risk obstetrics, urogynecology and endoscopy and infertility. He is the past president of the Kerala Federation of OBGYN, and he is the state coordinator of the confidential review of maternal deaths. And he has a very great work he has done as a state coordinator for the quality control standards in obstetric care in the Kerala, a unit project of Government of Kerala and NICE International KFOG. And that we know that Kerala stands first in the less MMR all over the country, and it's a great achievement. And sir is the pioneer to make this possible in Kerala. And on this day of the safe motherhood, with the right person to talk on the reduction in the maternal mortality. And we welcome you, sir, and over to you for your kind words, sir.
Thank you very much. Thank you to all these stalwarts sitting over there. Rajeshri, Jayarani, Preeti. I see the veteran there, Savitri Subramaniam's name is there. And of course, Sunita and my own colleagues from Kerala, Sangeeta and Pramila, Shanti ma'am, all of you who have been working as representatives of one of the first societies of gynecology in India, the Southern Society or the Society of Chennai. It's a great honor to be asked to share this platform with you on this occasion where you are considering safe motherhood as your main theme. And I am sure Chennai will have a different status when the next SRS comes. At the moment, I think you are not first, second, or third, but soon I am sure you will take that position. The way you have been doing, the systematic approach Tamil Nadu has taken, I am sure that you will overtake all of us. I have no doubt about it. Now, coming to the topic that I have been asked to discuss with you, that is, can I share my slide, please?
Ma'am, sir is going to share a slide now. Or?
Yeah, can I?
Sir, yeah. So if we want the presidential address, sir, and then I think, sir, you can do as you like, sir. Yes, sir.
Can you see my slides?
Yes, sir.
Yes, sir. Yes, sir.
Okay. So I have been asked to talk to you about, oh, sorry. This is just part of the inauguration. Talk is later, is it? If that is the way, that's fair with me. We'll just keep this on, slide on, but then tell you what exactly I have in mind about you. My association with the Chennai Society is long lasting, and as well as it started a few years ago. And I can still remember from the maternal mortality angle, safe motherhood angle, the person I respect most was one of your earliest workers, Sri Padmanabhan, who later, of course, became All India figure and then started to work. From then onwards, Tamil Nadu has always worked very systematically. If you haven't come to the top, it is not because you haven't done enough, but because your problems are worse than what that is there in our states. We are privileged in Kerala because of many other aspects. That is why we are there. It's not because of our work alone. The type of literacy that we have, the road connectivity we have, the small state that we are, the literacy our women have, all these have contributed to help us. It is not just the obstetricians alone. We are very aware of that. Even when everybody appreciates Kerala for the work, especially Kerala obstetricians, we related, of course. But then we know the fact that it is not that we have been doing something very fantastic. Of course, we have committed ourselves, and my colleagues in Kerala have come together. I will explain that later on. But what you have been doing also is phenomenal work. I have no doubt that you will beat all others in the next few years. And with all my best wishes to all of you, and appreciating the hard work that you are doing, wish you all the best. Thank you.
Thank you, sir. Thank you for your kind words, and thank you for your motivation. And we really we pledge to you on this day that in Tamil Nadu, in par with Kerala, and also almost work all over the country with epoxy to bring it down still more, sir. Thank you so much for your kind words, sir. And I have the great pleasure, honor, and pride, and really very happy to introduce Dr. Preeti Kumar, who is the chairperson of the Safe Motherhood Committee of FOXI, who is the co-chair of the Maternal and Perinatal Committee, SAFOG, and who is a great organizing secretary of ACOG Lucknow 2020, and the Justosis 2019, and IAG 2018, and NZYF 2070 Lucknow, who is the vice president of the Lucknow OBGYN Society. And she is the core member of Prevention of Violence Against Women, Cell of FOXI, and she is the recipient of the Padma Bhushan Kamalabu Hospital Award 2020-21, and she is the recipient of Imaging Science Award of 2004, and she is the appropriate award, got the Appreciation Award by Health Minister for ensuring safe motherhood in UP year 2020. And she is the Society of the Liaison Officer of FOXI PIGO PPH project. And I know Preeti, I really look upon her, admire her, the way she's working in the, in this community rather. She goes with the community, she works with the, paramedical workers, staffs, and the ANMs, everybody at the village level, up to the committee score level, and make them aware and create a lot of public awareness among the staff and working people to improve the maternal mortality. And really, I've seen a lot of her talks, her videos, her pictures, whatever work she has done in the Safe Motherhood Committee is phenomenal. And I really thank Preeti for joining us. And over to you, Preeti, for your words.
Thank you, Dr. Jairani. I'm really honored and privileged to share the dais. I think with Dr. V.P. Pelli, sir, that's really an honor for me. Thank you, Dr. Jairani and Dr. Kundavi, the Secretary General, and all the senior members here and all the delegates who have joined. I will share few words, few experiences, what I have done. I took over as committee chairperson in 2020. Believe me, I have worked in several states at ground. I've done a groundwork in a state like Uttar Pradesh, Bihar, Jharkhand, even Tamil Nadu. I had been there, and Gujarat, and I had been to Madurai also. But looking at the scenario, I must tell you that we need to do a lot. Dr. Jairani, you have invited two senior members here, Dr. V.P. Pelli, where the Kerala, the maternal mortality is so low. And in the state of like Uttar Pradesh, we have a maternal mortality of 167. A lot to be done. And I will share just few experiences. We did a FOXI Vistrit project in Jharkhand. In private facilities, and you will not believe only 30% were the doctors and the healthcare workers were aware about the single step test. That's a fact. And only 20% of the healthcare workers were aware about the cutoffs for GDM, that is 140. And totally not aware about the counseling and the management. That's far, far ahead. But this Visrit project, which was supported by USAID, it brought a huge change in the Jharkhand society. And they have not started documenting, and now the system has improved, and we got praises from the USAID also. Then we did the PPH project, and recently I was in Patna. We always do a pre-training survey before we do any workshop or training programs. Most of the PGs marked as the minimum hemoglobin of 10 grams before a patient goes in labor. So if you don't have that aspect of prevention, how will you manage that? So Dr. Pally had been, inspiration for so many. We look at to him how best we can do for the society, and we can bring down that maternal mortality to 28 or 30, what is there in Kerala. But the journey is very long. A lot has to be done. Still, what I can share is, if we talk about PPH, active management of third stage of labor is still a major challenge, a major gap in the management of PPH in our country. I can show you several data. We have hard copies. We have pre-training survey. That's the major challenge in our country. We need to do a lot on active management of third stage of labor. So states like Uttar Pradesh, MP, Bihar, Assam, that the top northeast belt where the maternal mortality is still high, we need to work a lot. So I think everyone, nobody pushed me into doing this. Hardly I went to any of the webinars where I talked to doctors or traveled to places, but I traveled to places to do the groundwork, tried to reach out to ANMs, to staff nurses, to midwives, to whatever possible way we could find out what best can be done. I have utilized every day out of all 24 hours. I've been working hard for the last 3 years. So luckily I got one more year for COVID. So probably this year I'll finish off, but I think that whosoever takes up the next challenge have to work hard, because a lot need to be done in a country like ours. So thank you so much. And I will request each one of you, it's not somebody will tell you to do, but everybody has to take the onus. Everybody has to take the responsibility. And I'm happy to see that you have taken a panel on the government guidelines for ensuring safe motherhood. But the irony is that, Dr. Jairani, that private sector is totally unaware about what government is doing. And the government is not supporting private sector anywhere, knowing the fact that 40% to 50% of the deliveries are being conducted in the private sector. So the things need to be changed also at the government level. We run from pillar to post to the government of Uttar Pradesh, still trying to catch hold of them, but still we are doing our best. We have adopted 2 districts here. I was telling here that 1,200 deliveries are conducted in that particular district in a month, but only 4 OBGYNs are there who are qualified. So we need to work on those areas where, they basically contribute so much of maternal mortality. So I think we should focus our attention more towards the ground realities of our country. I think Dr. BP Pally has touched the pulse of Kerala. He has worked on that field focus. He has focused his attention on that, and that is why he could achieve 28 to 30. I think many years, maybe 6 to 7 years, I think we will be able to. But for last 2 years, I have worked a lot with the government sector, and we could reduce up to 15 points. There was a decline in the maternal mortality. So these are small steps, but when you really work hard, then I find it is just a drop in the ocean. So I wrote to Dr. Arul Kumaran when I listened to her conversation yesterday when Dr. Kavita was, so I wrote to him, sir, I am working, but it seems to be just a drop in ocean. So he said, you just keep on doing, definitely you will achieve one day. So collectively as a Foxy, we should come forward. Every member, even I think from the private public facility, they should also focus their attention. The referral is very weak. The referral is very weak in our center, in our country. So that needs to be strengthened. So a lot of things that need to be done. So if I keep on speaking, I can speak on for for a longer period of time, but the time is less, so I'll not say much. But definitely, to ensure safe motherhood, we need to be very focused, and we need to understand the ground realities of our country. So South India is doing very well, but Northeast, we need to focus, and we need to really work out. So Dr. Pelli sir, I'll invite you to UP. So please come and guide us how we can bring down the maternal mortality, because 167 is a big target. And it's a huge, number where every day mothers are dying and they are not being reported even to the government. So we adopted 2 districts on National Safe Motherhood Day, Sitapur and Fatehpur, and where there is no society of OGSSI, but still we will go there and do whatever best we can do. So it's a total district approach where we will saturate all the private and the public facilities. Thank you so much. And thank you for inviting and making me part of this forum. Thank you.
Thank you, Preeti. Thank you for these amazing words, which are really thought-provoking for all the OBGYNs here. Because though we have achieved a lot, still we have a part of our country still lagging it. And I really appreciate your ground level work, which is really amazing as a obstetrician to go down to the the real field and do your work. And I've seen a lot of your studies, your pictures, your photos, and the encouraging words and the inspirational talk. Everything matters much. And we really feel very happy to have you here. It has been great pleasure and honor to have you. And definitely,
Thank you so much.
Your vision in another 6-7 years, your UP will come down, and we all will work towards our Indian maternal mortality to bring it to the 0 level. That will make our country the real master.
And this, I think, just last word, midwifery is something that we should, I think, promote, because the institutions where midwifery is there, the cesarean sections have also dropped down. So I think there is a lot of hitch in taking up midwifery. I think that's the next way forward that we can definitely include in our activities and all. Thank you so much.
Thank you. Thank you, Preeti. Thank you for being with us. Thank you so much, all the senior faculties and the chief guest. Thank you, sir. Thank you, Preeti. Over to Rajshri.
Thank you, ma'am. Thank you so much. It's a privilege to introduce the chairpersons for the session. I welcome Dr. Sangeeta Menon. She's a professor, Department of OBGYN, Government TD Medical College, Alappuzha. She's got a career spanning 24 years in medical college, which has been filled with academics and teaching. Her driving passion is working with the reduction in cesarean section rates and maternal mortality. She's assessor for the confidential inquiry into maternal deaths, Kerala State. She's captain for maternal near-miss surveillance and response and a trainer in ORRT. She possesses an avid interest in public health and trains on Women and Health University of Kerala. And she's an active member of the medical education unit. We welcome you, Menon. We welcome you, ma'am. Dr. Pamela Menon. She's a professor, Amla Institute of Medical Sciences, Thrissur, Kerala. She's immediate past secretary, Thrissur OBG Society, and she's past treasurer, Thrissur OBG Society. She's past editor, Kerala Federation of OBG and Thrissur OBG Society. She has several awards, Kamini Rao Orator 2017 and Yuva All-Rounder Yuva Foxy 2016. Her special interests are gynec oncology and high-risk obstetrics. We welcome you, madam. I now request the chairpersons to take over and introduce the speaker of the three speakers of the session. Thank you.
Thank you so much, Dr. Rajshri. For the first session, which is on the current trends in maternal mortality and the measures to bring it down, I would be actually very foolish to introduce Dr. VP Pelli. Suffice to say that for us, I think he must be training the 3rd or the 4th generations of gynecologists in Kerala today. And for us, he is, for most people in Kerala, he is the godfather of obstetrics. And we are where we are today, thanks to him. Over to you, sir.
Thank you, Sangeeta. Can I share the slide, please?
Yes, sir.
Okay.
You can share the slide.
Yeah, thank you.
Thank you, sir.
Yeah, you can see my slides. Okay. Thank you very much to OGSSI for this occasion, and of course, bringing my 2 very close friends to chair the session. They are part of the whole exercise that we are doing in the state of Kerala. Those with first-hand knowledge, as well as full of support for all that we have been doing right from the inception of the confidential review of maternal deaths. I'll probably take you through how we achieved what we have achieved so far. But
Chitrakala, can I help, sir?
yes, screen sharing has stopped.
Sir, can you please click anywhere on the PPT so that it will change, sir?
Screen sharing has stopped as the share
Yeah.
window is closed.
Screen
Can I
sharing is
say
not
okay?
there.
No, sir.
Sir, no, you're not sharing the
Screen
screen.
is not
So you have
changing
exited
now.
the share screen, sir. You have to share again. Please share this. Yeah.
Yes, sir. Yes, sir. Yes, sir. Slideshow.
Is that okay now?
Yes, sir.
Yes,
Yeah.
sir.
Okay. Why we are all concerned about the maternal mortality ratio? Because internationally is the best indicator of the health status of a society or a nation. And of course, the respect that the women in that society enjoys. And that is why all the nations actually talk about MMR, the country. Trends in MMR, that's what I have been asked to review. Globally, there has been reasonable decrease, except in sub-Saharan Africa. And unfortunately, in Africa itself, Nigeria contributed a major part, partially because they are a very populous country. But even otherwise, we always talk about sub-Saharan Africa as though it is from another part of the globe. It is really, but unfortunate that there are probably many factors which play together, putting them in that particular state, political, economic, and all the problems they had faced all these years. But unfortunately, the fact remains that sub-Saharan Africa is the one that keeps the maternal mortality ratio bad for the whole world. Now, if you look at it, in 2020, it is reported that about 287,000 maternal deaths occurred for an MMR of 223. And sub-Saharan Africa has an MMR of 545. Nigeria alone contributes 82,000. But second rank comes to India, 24,000. But we are a much bigger country, much bigger population. And when you take the ratio, of course, India's ratio is so much better. Now, the reasons for maternal mortality across the world, if you take, it practically remains the same. These are the same causes that I was talking about when we started this whole process, and unfortunately, it remains the same. Hemorrhage leading the front. High blood pressure coming as second, and infections as the third. But if you look at the trend in India, as we said in the beginning, India is making very steady progress, but there are weak areas, as Preeti already told us. The North and the Northeast, unfortunately, have their own major issues, especially Assam and UP and Bihar. But still, in spite of that, MMR of India in 2020 has come down to 103. Some claim that it has already reached 97. And the aim for India that is set by the government of India is 70 by the year 2030. Southern states have been doing well. Kerala is reported to have reached MMR of 19, but we know that it is not true. It is not 19. It is actually about 25 to 28 in the year they were reporting 19, because that's a sample registration system that 19 was put up. The real numbers we know for the whole state of Kerala, and we are honest to admit that MMR, when they said it was 19, it was nearly about 25, 28. But still, that was something better than what we were aiming for. In 2020, our aim was to achieve an MMR of 30, and we could achieve it by 2019. That we were all very proud about. I think the obstetric community of Kerala is very proud that it could achieve it, not by itself. It is the good support of the government of Kerala. If you look at the trend, this is something that is pictorially represented, and by 2018 to 20, it has come down to 97 for the whole of India. And pictorially again, if you look at it, darker it is, lower the MMR. So you can see Kerala is fairly dark. Maharashtra comes next to that. Chennai, yes, a little lighter, but I'm sure, as I said, I am very sure about it. You will catch up, you will become darker than all the others in no time, because the way systematically things are happening in your state. If you look at the whole state, you can see that we are proud to be up there in Kerala, but Maharashtra comes second. And as already Preeti told us, Assam unfortunately remains the worst. Just above that is Uttar Pradesh, Madhya Pradesh, and all those countries are there, all the states are there. So in the trends in the whole state of, the whole of India is certainly progressing, but still a lot more to achieve. MMR of 70 by the year 2030 is certainly achievable the way things are going at the moment. For the state of Tamil Nadu, as we saw a little while ago, it is already reached 54 and they are rapidly progressing. And I am sure they will reach, as I said, in the next 5 years, the top in the country. The fact about MMR for the country that you have to remember is health is a state subject. So from that, maternity care is a state subject, but there is no money for the state. Most of the states, you are lucky in Tamil Nadu. I'm sure you are financially much better off, but we in Kerala, what we can say, hand-to-mouth assistance. So we have to depend on financial support from the government of India. And thankfully, that is coming. The only question is how well we are utilizing it. What is recommended is to achieve what we are aiming for, we should have a resilient health system. We should have a community-centered healthcare approach. And the women should be able to control the reproductive health of their own. Until that comes through, maternal mortality will remain high. That's a prediction. That's about a lot of talking. Coming to practical terms, what exactly we can do, that is what we are going to do today. What we should do as the way forward is identify the reasons for maternal death and then take preventive steps. That can be done only by audit. So do proper audit that will tell us why mothers are dying, and then that also will tell us what can be done to prevent that happening again and again. So the whole purpose of audit is to find out, and I'm sure you all know about, you would have heard about all these different types of audit, verbal autopsy being the most basic, then the facility-based, but possible only if there's a facility-based deliveries. Many parts of our state, we know that the home births are so many, institutional births are so few, that facility-based audit may not have any relevance. We are happy and privileged in the state of Kerala because for a long time now, our institutional delivery rate had been near 100%. The other type of audit is near-miss audit, which also is possible only if you have records of the care given to the woman. And that again is possible only if you have institutional deliveries. And as generally accepted, confidential review is the top, the best type of audit that is acknowledged as the best way of auditing maternal deaths. We'll come to that later on in the discussion. But there's no use auditing if you don't have follow-up action. So that is why in 2000 itself, or even a little earlier, to 1997 itself, WHO came out with a suggestion that forget about maternal death audit, MDA. They stopped saying about MDA and started to say that it has to be maternal death surveillance, that is audit and response. Unless you find out and then act on it, what's the purpose in finding out? That is the reason why they said our approach should be MDSR, surveillance and response. And for that, there are different ways of doing it. And in the state of Kerala, right from the time the Kerala Federation was started in the year 2002, we decided that our top priority is to work towards bringing down maternal mortality. The Kerala Federation, the only committee that it started with was mother and child, looking after mother and child, or maternal fetal medicine committee. And we said that we are going to work towards confidential review of maternal deaths. I will briefly discuss the background to you later. Then as an offshoot from that, we realized what we need is a systematic approach to emergency obstetric care. So we started emergency obstetric care and life support in the same line as some of the Western countries have been auditing and then acting. You would have heard about the UK as well as Australia, as well as America. They all have their own systems of auditing. And we realized that we should insist on certain standards of care, at least for the common causes of maternal deaths. And that is why quality standards as a project was launched. And thanks to NICE International and our then health secretary, Sri Rajiv Sadanandan, who brought NICE International to Kerala, and we started quality standards in obstetric care. Soon we realized our maternal deaths are coming down. And if you look at auditing only maternal deaths, there are certain parts and certain hospitals, parts of the state and hospitals, we may not have a maternal death for months on. So we said, instead of that, why not audit near misses, which was very much recognized. In fact, by late 80s in the UK, they started to do the near miss audit. And we thought out another project that is called MDNMSR, starting for maternal death and near miss surveillance and response. This was an offshoot from the audit and the quality standards that we are working. I'll explain that again little later. And just like in terms of EMOCALs, emergency obstetric care and life support, at the institutional level, we realized that whenever a complication occurs, there should be a team which will come to the rescue immediately. And that is why we brought out this concept of obstetric rapid response team in every hospital. And of course, of late, we started this project called PPMD, that is prevent the preventable maternal deaths. How exactly that was thought about, again, I will come to in a minute. This is just a snapshot of the way we started the confidential review of maternal deaths. Some of these figures, this at least, this gentleman you may know, this was Philpott, Gwyneth Lewis, Mathai Matthews, very much known to all from Tamil Nadu. And of course, these are Kerala officials like that. And these are Kerala officials over there. He was from WHO. And that is how we started our first CRMD program. And he was the then health secretary, Sri Bharat Bhushan. And later, we had many, many meetings before we decided on how exactly to do the quality standards in obstetric care. These are representatives from the NICE International who worked with us. And then we decided how to address the issue of hemorrhage as a cause of maternal death. Simple steps. We decided on just 5 steps. And the first among them was have active management of third stage of labor in every delivery. Not just saying active management of third stage of labor. Then we defined what exactly is the active management of third stage of labor. Because when you work on it, you see that active management of third stage is so different for so many people. Somebody will say you give 5 units oxytocin, but if you ask how, they will say IM or IV, taking how much, when to give, at the delivery anterior shoulder or after that, all sorts of variables are there. So we standardized and said, give 5 units, diluted to 5 ml, give it taking 5 seconds at the delivery of the anterior shoulder or within 1 minute of delivery of the baby. Give another 10 units, IM. Put another 20 units in a drip and run it for 2 hours, like that. So we specified, that is quality standards. For hypertension, we decided how much of max health to give, when to give, what regimen to give, what to use for controlling acute hypertension, like that. That is quality standards that we brought in. And these are some of the meetings. Our state chief minister here actually releasing the quality standards that we worked on with the British counterpart, not British health secretary at that time. And we identified by this maternal death audit why mothers were dying. And as you can see here, the red remains red. Hemorrhage as the leading cause, hypertension as the second one. But again, sepsis, heart disease, amniotic embolism, pulmonary embolism, respiratory and viral, and of course, some of the other causes which contribute to maternal deaths in our state, which almost the same pattern is continuing, but the total number is coming down, so MMR is coming down in the state of Kerala. This is as of the latest, the other causes like liver disease and all that. So that is how we identified the major causes by auditing. Then the second step, as we said, was surveillance by itself is not enough. You have to respond to it. So we decided how to address the issue of hemorrhage. And we are at a state at the moment where we can address the issue of hemorrhage much more effectively than we could do, say, 15 years ago. And for that, there have been many developments. We developed this clamp that was called transvaginal uterine artery clamp, which can be applied vaginally to occlude the uterine arteries vaginally, to be used without anesthesia by the obstetrician on the spot or even a midwife on the spot. So that is transvaginal uterine artery clamp. This was the clamp that we developed to clamp the aorta in case where we are tackling placenta accreta spectrum. And this is the clamp that we developed for the transvaginal uterine artery clamp, provided as a whole set like that with retractors to be used. And this clamp, slightly different in the shape at the moment. This is an L shape, as we call it. We have a T shape also, which is supposed to be a little easier to use. We had the suction cannula, which I am sure you all know about. Dr. Samartharam has come and traveled all over Tamil Nadu to promote it, and cannula like that. What we have done of late is take the same principle and then have disposable cannula, plastic disposable cannula, which is available, readily sterilized, and then use it and throw it, which will cost us only about 250 rupees each piece. Almost the same as the suction tube that you are opening when you are doing a cesarean. Same way, like that. You have a tip, multi-hole tip like that. So new development in that way. We feel that hypertension for a long time has been played around. Unfortunately, alpha-methyl dopa has disappeared from our market. I think it is high time the government takes the lead to bring it back. You know, the reasons are many, which we don't want to discuss in public. But labetalol, as everybody is talking about, is not the ideal antihypertensive as the first line antihypertensive. It has 2/3 beta blocker effect. If you give it for a long time, it causes growth restriction of the baby. So alpha-methyl dopa, I think government should take the initiative to bring it back. Amniotic embolism, only two associations we can talk about, and that is hyperstimulation. If there's a hyperstimulation, that leads to it. If there is smooth muscle relaxants like drotaverine or epidocin being used late in labor, that can lead to amniotic embolism. This is our conviction. If you ask me, where is your proof? I'm sorry, I don't have a randomized controlled trial to talk about it, but this is what we believe is contributing. When you talk about sepsis, we emphasize this point. Cleanliness is godliness. Clean, clean, clean. That's the first step. You know about the different cleans that we talk about in public health, but cleanliness starts at different levels. We should have, as far as possible, for delivery, disposable sets, which I think our government has started to supply long ago. I am sure your government also has adopted the same thing. And forget about sterilization with sidets and all that. Forget about the idea that by putting scissors in sidets, you can have sharpness longer and all that. Sidet sterilization should go out of our labor rooms. It should be steam sterilization whenever possible. And everything should be steam sterilized, or of course, ETU and other methods of sterilization. So with all these, as part of our policy, then we had periodic meeting with the health officials, and this was the health secretary, Rajesh Sadanandan. She was the health director at that time, and with them, and we had the NHM director also, and with their support and their appreciation of what we were doing, rather than as a boss and a servant attitude, they appreciated what we were doing, and such collaborative work helped us to achieve what we achieved. So we could improve and improvise new methods to achieve the target. We wanted to disseminate that information to the obstetric community of the whole state. What usually happens is, whenever we talk about all this, presented in conferences, a few people come very regularly for every meeting, but about 60 to 70% of the real workforce don't have any time to go for conferences, and they will not go for such meetings. They are not invited either, and they miss out on the new developments. So with that, we should take this academic exercise to the periphery. That is how the maternal death and near-miss surveillance and response was started at the district level. All the hospitals in the district are represented in that monthly meeting. They share what has happened the previous month. If there was any maternal death, without revealing the identity, they will discuss the reason for it and how to prevent it. But more importantly, they will discuss all the near-miss cases they have to deal with and what lessons to learn from that. It has become such a good camaraderie activity. And I'm sure if your state starts it, it will be a great achievement. It's a district level. Obstetricians, the private and the government get together every month to discuss the near misses. I was listening to Preeti, who was feeling sad that the private healthcare is not on board. One of the best things that has happened for Kerala is there is no distinction regarding these things between the private and the government. In fact, the private health system doesn't support, the whole system will collapse in Kerala because 70% of deliveries in the state happen in the private sector. But we don't make any distinction. All of us move together. And maternal deaths are just reported during this meeting without discussing, because the anonymity has to be mentioned whenever we discuss maternal death. This is different from what Government of India had been talking about. I know many of you, even in Tamil Nadu, have this district level magisterial audit for every maternal death, which so far we have been able to tell our government that doesn't really do much good, because you are pointing fingers at the treating team or somebody's lapse, exposing them in front of the relatives, and thereafter every attempt to cover up. And if that doesn't happen, shouldn't happen, then we should have anonymity and the fear that there is no punishment even if you tell the truth. And that is why confidence review of maternal deaths was important. And MD and MSR was a step forward. I told you about the obstetric rapid response team. Every institution should have a small team. The obstetrician, labor room nurse, but another person who is really good at cannulation. So if there is an acute collapse or acute problem where you need support, somehow you bring this team together, which may have only 4 members. But one of them is good in resuscitation, giving CPR, starting IV line and all that. Even small or big centers should have an ORR team. That is what we recommended. And we train the nurses and doctors so that they will be able to come to the rescue at that time. Then WHO came out with a new directive. By 2025, we should prevent all preventable maternal deaths. And that is because if only we achieve that, we can achieve the MDG by 2030. And the MDG, the goal is not the MDG, it's Sustainable Development Goal, SDG. By 2030, we should have an MMR of 70 globally, and no country should have an MMR double that. That is 140. So to achieve that, we should have preventing prevented the preventable maternal deaths by 2025. And that is why we started this. The other advantage of this is we brought down the issues that we address when we do this IMOCAL's training program. We take only one day and we go out to the district, from the district headquarters to the periphery, to the taluk level, and so that the small hospitals there can come together and get trained mainly on preventing hemorrhage, addressing hypertension, addressing an acute collapse, and preventing sepsis. These are the 4 topics that we emphasize in that one-day program, in which obstetricians as well as labor room nurses are brought in. We may have to train for the whole state of Kerala. We have to train nearly 3,000 obstetricians and 6,000 to 7,000 nurses who are there manning the labor room, because we have about 500 delivery points in the state of Kerala. So the lessons we learned are partnership between the administration and obstetric community is essential. Respectful relationship, not boss and servant relationship. Respectful relationship between the two. And efficient leadership with mutual respect is essential at the government level and at the level of the profession. So then only they can work together. We came out with our observations on the maternal mortality. I'm sure some of you would have seen this. Why mothers die, 10-year experience like that. And suicide of late is emerging as a major cause of maternal death. The other observation that we have made is in the state of Tamil Nadu, I think it is good, but in Kerala, it is still to improve. Insurance cover for maternity care has to improve a lot, and data collection has to improve. Finance is the most important element required for this. And in the government sector, it has to come from the center and the state so that drugs and equipments are available for the delivery points. In a democratic setup like ours, political support is critical. The importance of nurse midwife. Earlier there was talk about the midwifery. Preeti was saying, yes, nurse midwife. Nurses have to be empowered to administer oxytocin, to apply the transvaginal urinary clamp and the suction cannula. Encourage male involvement in maternity care, and in all our hospitals in the state now having a companion in labor, a male companion in labor is accepted, and they are provided privacy. The major causes have to be approached. We are in the best phase to address that regarding the hemorrhage, but regarding suicide, it needs a multi-pronged approach for that. And together, if we all work with the government, I'm sure the future is bright and we can bring down the maternal deaths in our state. Thank you very much once again for this opportunity, Rajeshri. Okay, bye. And our chairpersons, Sangeeta and Pramila.
Thank you, Paili sir. It was indeed an honor to be a chair for this session, and I'm really humbled by this opportunity. And as sir has rightly pointed out, yes, it takes a lot of effort from everyone. Okay, not only government side, from everyone in the private side, government side, everyone has to move together to achieve this. And as sir has shown all the 7 methods by which we have been trying this different programs. And I should say that all the 7 are his own brainchild. We are all helping him to do that. And all this, the passion with which he works actually, it is a promoting factor for all the youngsters to join behind him. And if you go through his mails, actually, we would have slept off. His mails comes at 1 o'clock and 2 o'clock at night. Only when we wake up the next day, we will be seeing his mails. So he's working even at night, 1 o'clock, 2 o'clock, he's working to make sure our mothers are safe. So hats off to you, sir. And among the two new innovations, I think that suction cannula and the transvaginal urinary clamp has drastically changed the management of PPH. So I think that is something which we should promote all over India, even because this is something which can be used in any areas. It doesn't take much cost. Anybody can be trained with that. Even staff nurse can, even our staff nurses, they apply it. So you can even teach them to apply it. So these 2 methods actually is going to really change the scenario of PPH management in India. Sangeeta, madam.
Yeah, I have actually the same sentiments to echo. We have all been trained by Sir and used all these instruments and found it at a time when you're alone, when there is not much help. It's these instruments who are your friends. And I think by and large, all delivery points, irrespective of where you are, should have these with you. The transvaginal uterine artery clamp is a lifesaver. It gives you peace of mind. And it's so easy to apply. It's not rocket science. So I fully agree with what Pramila had said. And I'm very thankful that we work with Paili sir. And he's made all our lives simpler as well. Thank you so much, sir. Dr. Rajeshri, shall we go on to the next talk?
Yes, ma'am. Yes, ma'am, please. Sunita madam's, yeah.
So,
Ready.
Pramila, will you do the honors?
yeah, yes, ma'am. Yes, ma'am.
उनका लेक्चर चालू करवा दो मैं ज्वाइन करती हूँ.
So it's my proud privilege actually to introduce our next speaker, who is none other than Dr. Sunita Tendulkar. She is the head of department and chief of IVF and Endoscopy Center, Ruby Hall Clinic, Pune. And I think if I go through all her achievements, that itself will take more than 10 minutes. So I think she needs no introduction. We all know her achievements. She has got an extraordinary achievement that she's the India's first stem cell baby creator and world's first at the age of 45 in 2018. So over to you, ma'am, for your talk. We are all eagerly waiting for your talk.
Ma'am, you will have to unmute, ma'am.
Unmute. Thank you so much. And I'm in Udaipur where we are doing the CME. And it is so beautiful to see all of you. And Jairani, thank you so much. Shanti madam, Meena madam, Rajeshri madam, Pramila madam, Kudvi madam, how are you? So lovely to see all of you. And it was wonderful. It's very difficult to talk. Hi, Preeti. It's very difficult to talk after Dr. Paili. It's a legend, but I'm so fortunate that I'm sharing a platform with Sir. So let me start without wasting much time. Namaskaram, all of you. And thank you for an opportunity, Safe Motherhood Committee, Preeti. Thank you so much. The amazing work, what you are doing is unbelievable. And one second, let me talk about Preeti. You know what? I always feel I'm proud of this lady. If I would have been a Safe Motherhood Committee chairperson, I don't think I would have done even 20% of the work what she's doing. And that's because of her amazing idea, creativity, and perseverance to ensure that those ideas, they get implemented. I see her coming in the conferences, working with the paramedical staff. She's not bothered about the limelight of the main conference. She is doing her pre-congress workshops and she is moving on to the next destination. Preeti, I'm so proud of you. And Foxy need people like you, leaders like you. Thank you. Now I share my screen again. Friends, the topic given to me is FGR. I always believe that advances in science is always for the betterment and we should change. Why there is so much of a clinical update? Because with the IUGR, the understanding of the subject, the modality of the diagnosis, the Doppler studies, the sonography, the fetal medicine, the complete compartment, baby is seen as a patient separately because of these people, and that's why we can do it. So there is a paradigm shift, and we call it as a small for gestational age baby when they are less than 10th percentile, and they can include either constitutionally small or a pathologically small. Constitutionally small means the baby is small, the growth size, but no maternal or Doppler problem. While growth rate restricted means there may be some recognizable maternal pathology apart from sonographic small size of the baby less than 10%, there may be a Doppler abnormalities, or it may be idiopathic. It means everything is normal. This is very dangerous. Everything is normal, baby is not growing. So you feel sometimes so scared, sudden IUD can happen. The problems of a FGR, the morbidity and mortality, of course, we are all worried about, and with this various pathophysiological changes, the chronic hypoxia, which happens with this, with certain times giving us the CTG changes. But what is very important is to find the cause in that particular patient. So these are the maternal and the fetal causes. These are the maternal, there may be problem, there may be a placental problem, there may be umbilical problem, or there may be a fetal problem in that particular patient. It is important to note that there is always a confusion between the etiology and risk factor. For example, chronic hypertension, kidney diseases, SLE, these are labeled as maternal etiology, but I should think that these are the maternal risk factors which may give us abnormal placentation or a placenta-mediated FGR. I'm not going to go in details about all this, but what is important to understand is FGR is principally not the consequence of a reduced maternal nutrition, but reduced transmission of a maternal-fetal supply. And it has been suggested that depending upon the gestational age, when we were residents, we used to talk about symmetrical and asymmetrical. Symmetrical means less than 32 weeks from the beginning, like 20 weeks, 24 weeks. So everything is symmetrically. While late onset, that is more than 32 weeks. Now, early onset FGR, it has a less prevalence than the late onset, 0.5 to 1%, but underlying placental pathology is frequently similar to that which observed in a preeclampsia or other. It is easy to detect the FGR, while late onset is more common, 5 to 10% of the cases, but usually it is mild, associated with preeclampsia, and mainly because the challenge is not so much because patient has reached to the near term in a salvageable age. So the management of a late FGR is relatively simple. This is a very important last paragraph. The diagnosis of late FGR is on adaptive changes in a cerebral circulation. Now the baby is not getting adequate nutritional, what baby used to get. And then the baby, we all know that the cerebral circulation, the redistribution, the brain sparing effect happens, and there is a low resistance to the flow into the middle cerebral artery, so that more and more flow will happen. So there is a low cerebroplacental ratio. And that's when your sonologist or your fetal medicine consultant says, you know that you are reaching to the late onset, this thing. Now, early prediction is very important. So one should be taking the history, maternal age or undernutrition, overnutrition, anemia, associated condition. So when patient comes first time for an ANC registration, it's mandatory for all of us. It is mandatory for all of us to take a detailed history. Otherwise, we'll miss many things. Biochemical markers, low PAPE, very important, and this sonographic marker. Now, other probably the AFP and all, we don't do it, but double markers, low PAPE and beta SCG, we always do it. And these ultrasound marker. Now, if at 12 weeks of this, if there is a low PAPE, if the uterine pulsatility index is high, I know that this patient can go in FGR. And on the top of that, elderly age or the ART conception or associated PCOS, we all know, or a previous history of a FGR, we all know that probably. And that's what I say, we should work on a preventive obstetrics. Today, at every city, we will have these markers available, the sonography facility available. We should take advantage. And if we don't have in a smaller cities, in a high-risk patients, where you feel they are prone, you should be sending it to the city to do these basic tests. There is no single test which can be a prediction model. It is always the risk factors which makes us think that probably this patient will go. This is a very complicated and crowded slide, but what they have done is from the maternal risk factor to all the categories they have made, and they say if there is a major risk factor, serial sonography measurement should be done from 26 to 28 weeks, and maybe that patient should be referred to the tertiary center. And if they have 3 or more minor risk factors, then also this patient should be in a specialized if you are in a smaller cities. Now, prevention. Is it possible to prevent? So first thing is to prevent, you should know in which cases there is a high risk of it. If she is smoking, you ensure she stop it. If she is having a habit today, I won't say that smoking and alcohol is only in a metro city. It is everywhere. Patient's gestational age weight is not happening. Can I give an aspirin? Yes. If I'm suspecting preeclampsia, if there is no suspicion of preeclampsia, then FGR cannot be reduced just by adding an aspirin. Low molecular weight heparin is never recommended. So how do I detect? First, most important thing is confirmation. The last menstrual period, whether she has a regular cycle, go in a depth. What is her gestational age? And is there a sonography done first trimester? First trimester sonography is the most accurate. The early sonography at 7 to 8 weeks is the most accurate. And if she has not done and in low Sears result, then symphysiofundal height. Clinical palpation. I think we all in a residency used to believe 40 years ago, we all abdominal palpation, emptying the bladder, preferably the same person, taking the same measurements. And we used to do that. And we used to diagnose many just by clinical palpation of the patient, measurement of a symphysiofundal height. And then accordingly, I can send those patients. If I don't have a facility, I'll send it somewhere. This is a FIGO 2021 saying that symphysiofundal height measurement at 32 to 34 weeks of pregnancy is reported to be approximately 65 to 85% sensitivity and 96% specificity. So don't leave your clinical examination. Remember this. Now, sonography. We all know that these are the standard sonographic 4 measurements. Everyone does it. Fetal weight is equally important. I'm joining you. Most studies concluded that we have to do these biometric measurements, and associated, we should do the Doppler. Remember, the Doppler has moderate predictive value in a severely FGR. It's a very important. And I will say that the Doppler is the one which helps us to decide how we terminate. I'm going to talk about it. So how do I manage this? Is there anything I can do? The primary management challenge arises from the risk of fetal deterioration, stillbirth in a pregnancy is undergoing surveillance. Suppose we know that patient is undergoing FGR, but we feel that we can prolong her pregnancy for another 2-3 weeks. And suddenly, if we lose that baby, that's a trauma. That's a difficult situation. And if we deliver, then what about the neonatal morbidity and mortality of this preterm labor? We have to balance all these. And of course, we need to see that there is no genetic abnormalities, which is more commonly will give a below 32 weeks FGR. I know in 15 to 20 minutes to finish this topic is so difficult, but I'm trying to make it as pertaining to the point as possible. In late onset, cardiovascular deterioration in response to fetal hypoxia is predominantly confined to the cerebral circulation. I'm saying you again and again, when it is a late deceleration, late onset after 32 weeks, always remember, let them talk about cerebrovascular dilatation of these, because there will be a low resistance and more flow going brain sparing effect. Likewise, the optimal management setting in a late onset FGR is, interpretation of this. And it should be, you should have a high fetal medicine person or your radiologist, the high-risk obstetrician, the neonatal unit, everything. And in those circumstances, only you should be delivering this patient. Now, optimization method. In a high-risk population, umbilical artery Doppler, yes, it should be the primary surveillance method for a FGR patient, and CTG alone may not be. You may have a normal CTG in FGR, so just don't depend on a CTG, but CTG may be important after you diagnose for a monitoring of this. Is there any empirical treatment I can? No. First is do no harm. Do not waste too much of money. Do not waste too much of a time, and base it on at least one modicum of logic. It's very important. Aspirin, as I told you, not for FGR, but if you are suspecting ecosprin, then you can think about giving. What about the adjuvant therapy? There are so many adjuvant therapy, oxygen, nutrition to the lady, hospitalization. If I'm suspecting 26 weeks, severe IGR, 5 percentile growth, shall I admit her? Shall I keep a bed rest? Shall I give her a beta mimetic? Can I give her a oxygen 2-3 times? There are so many things which comes in a mind, but not a single treatment is evidence-based. But believe me, friends, I want to tell 2 minutes my experience. I do give these patients oxygen 3 to 4 times in a day. Now, if they cannot afford its hospitalization at 26 weeks, first thing she will ask you is how long I will be hospitalized. What I do is I tell them, just get hospitalized. Let me pull out the pregnancy till 28, 30 weeks. I give them oxygen 3 to 4 times. And if she's non-diabetic, she's not elderly, I'm seeing that HbA1c is 5.2 or 5.5, I give her alternate day 5% dextrose over a period of 8 hours. Is this therapy evidence-based? It has given me a fantastic results. It gives me a continuous growth of 3 percentile, 4 percentile, that's enough. Now, what about patient who says, no, I can't hospitalize? And absolutely, you can't hospitalize every patient. What I tell them is get up in the morning, sit in your gallery and take a deep breathing. 20 minutes deep breathing, morning, afternoon, evening. Do that. Let as much as possible, 2-3 hours in the afternoon and 7 to 8 hours in the evening, lateral position rest. Mother has a huge power of protecting the baby. I ask them to talk to the baby. Tell the baby that you are fine. Nothing is. We all know that the universe can help. The maternal power can help. She should be completely attached to that baby, and powerfully she should be talking to the baby. Other things, I make her take less carbohydrate diet, and more of a protein diet, especially if she has, again, too much of a weight during pregnancy, while other medication, these I don't think I have much experience. Most prenatal intervention do not show, the evidence don't tell you that it is steroid. Of course, when you are trying to deliver the patient, I'm not going to waste my time on that. Steroid and a Maxel for a neuroprotective, yes. One important thing, when you give a Maxel preterm baby, there can be chances of a PPH, and be careful about it. Timing of the delivery. These are the 4-5 slides, which is very important, and I would like to isolate. Now, if it is an isolated mild FGR, if there is no additional abnormality, fluid is normal, Dopplers are normal, and it's just the mild between 3 to 9 percentile, please don't terminate the pregnancy. Continue till 37, 39 weeks. And during that period, every week, do the Doppler monitoring of that patient. That's most important. For a mild FGR, more than 37 weeks, you can still do the monitoring with CTG, NSID, and NSTs, and 1 to 2 times the Doppler biophysical profile, and you can continue. Isolated mild FGR, we understood. I will continue. What about isolated severe FGR, where the estimated weight is less than 3 percentile? Then still you can continue till 36 to 38 weeks. But in this patient, please, at least twice in a week, please keep on doing her Doppler and middle cerebral artery Doppler. Very important to do that. Now, in cases of FGR with early Doppler changes, mild associated oligohydramnios, subinterval, maybe early signs of preeclampsia, but still you can monitor and continue between 34 to 37 weeks of pregnancy. But in this patient, try to do CTG at least twice a week, Doppler twice a week, and continue. Now, FGR with umbilical artery absent end-diastolic flow. You can still defer it to 32 weeks, but now at any cost, this patient has to be indoor. You need to do either daily or twice a day CTG NST and alternate day Doppler studies for umbilical artery and diastolic flow absent. And when there is a reversal of end-diastolic flow, again, hospitalization, but daily Doppler study and twice a day CTG NST, keep a very close monitoring. Friends, we sometimes get worried that it's okay, let me take out instead of losing, baby may be better in outside than in utero. But we should be little rest assured, especially if you have a facilities of in-house management of all, and try to do. IUGR with prematurity, equally dreaded combination. Now, FGR with abnormal ductus venosus, that is a problem. It means you have to deliver. So timing should be individualized. Now here, if it is at 26 to 28 weeks, then it should be a shared decision. You have to explain because neonatal ICU expenses, the parent should know. Associated prematurity complications, retinopathy, all has to be discussed and it should be a common. Shall I do cesarean section in all? Yes, those with the late umbilical artery, absent diastolic flow or reversal of flow, abnormal CTG you may think about. But otherwise, there is no, we all know that even preeclampsia patient, we can induce them very fast and they can go in a precipitate labor sometimes. Now, when you take a patient for a Caesar, lower segment is not formed. So you should have a mental image. You should know you will take a good incision. Lower segment approach is feasible. Take a small incision because a segment is not formed. With the Caesar, make a upward than the lateral extension going into the uterine. Remember, deliver the head with the fingers rather than the lower segment is thick. So probably it may give you trouble. And always remember, if it is unexplained, then placenta should be sent for a histopathological examination. This is very important. It may be a torch group of infections. You don't know. It may be the infarcts. It may be the lacunae. So it is very important. And long-term consequences. It's important that you sit with the parents and explain, today you might have saved the baby, but there can be long-term consequences in the adulthood for these growth restricted. So it's like a turning full circle. There is no single test. Decision before 32 weeks, preferably in the higher center. This is a very important. The trouble with many of us is that we underestimate the power of simplicity and we tend to mistake the moment of achievement. We try to deliver that patient. Remember, whenever the baby is uneasy, there can be a premature labor contractions. And that is a sign that baby is not ill. And then you can wait. Simple technique is daily fetal movement count. I believe in, it was my thesis in my post-graduation. And I also believe in science, which is compatible with spirituality. I tell my patient, believe in the universe and send the positive vibrations to your baby. You only can protect your baby. Friends, daily movement count is such a fantastic at a low resource setting. And patient, you should tell her 9 o'clock, have a breakfast and just lie down. 1 hour and feel the count. In 1 hour, she got 4-5 count. In a day, actually 12 hours, it should be a 10-minute, 10 counts. So that builds up her confidence. That gives her time to talk with her baby, connect with the baby. So friends, I try to talk about FGR in as much easily possible. I also humbly request all of you to bless me for this election, which are going to be on 1st of August to 10th August. Thank you so much. Thank you for your patient hearing. Thank you.
Thank you, Dr. Sunita. That was really very exhaustive and very well done. I fully agree when you say that there was a time when we looked at IUGR or FGR clinically. But today I think FGR is more mathematics than clinics because we rely on Doppler so much, and rightly so. With the papers by Gratakos and Figueras and the Barcelona system, we've been able to categorize the FGR into stages. And I think the routine ultrasound that most of us do at 34 to 36 weeks, what we call the growth scan, has really taken off the element of late onset FGR, not fully taken off, but at least reduced it and reduced the unexplained stillbirths. And as you had already said, the CTGs, I don't know, when we were students, we were taught that CTGs were more intrapartum tools rather than antenatal tools, whereas the antenatal tool was more of the Doppler. And rightly so. I just have one comment to make, that, you know, very often we have a very small baby and we're following up with Doppler. You get stuck at 34 weeks. You're very tempted to induce, and you know it may not work because the cervix is long. But I think just the day before, on the day of induction, a Doppler is good, because very often we find that very many of them have an absent flow, and then you need to do a cesarean section for them. Thank you so much, Dr. Sunita. It was really interesting.
Thank you, Sangeeta ji. Your sum up was fantastic. Thank you.
Thank you, ma'am.
Madam, unmute.
Camilla, ma'am, we have to unmute.
Unmute, ma'am. Unmute.
Madam, for that excellent talk. And as you rightly said, simplicity is the basis. And in your talk also, I think you made this very complex subject into a very simple talk, which everybody can follow. Thank you so much for that excellent talk. Shall we go ahead with the next speaker?
Yes.
Yes, ma'am. Introduce the next speaker, ma'am.
Yes.
Sangeeta, madam.
Yeah, it's a pleasure to introduce a young, vibrant, and very dynamic speaker, as in Sudarshan. He's a consultant fetal medicine specialist at the Mediscan Systems. I think I have the honor of seeing him as a very young child when I was training with Sir. He's done his undergrad from PSU at Coimbatore, DNB in obstetrics from the railway headquarters at Chennai. He's got a fetal medicine fellowship, trainer, faculty, the N number of workshop lectures. We've all listened to him. And I'm really looking forward to hearing you, Sudarshan. So over to you. He's going to talk to us on preeclampsia screening and how really it could be a tool to optimize maternal outcome. Sudarshan?
Rajshri, is Sudarshan here?
I'm calling, ma'am. He was here. Ma'am, I'm just calling him. He was here.
All right, all right.
He's not picking the call.
Right?
Ma'am, he Sudarshan is just logging in, ma'am.
All right, all right.
Hello, madam. Can you hear me, madam?
Yes, we can. Sudarshan, we listen. Yeah, I finished introducing you, but you can go ahead.
No, I was
We're
just
waiting to listen to you.
Yes, madam. Okay. I hope you can see my slides, ma'am.
Yes, yes.
Very good evening, and I thank Jairani madam, Dr. Rajashri, and the OGSSI team for getting me to be a part of this session today. And this session, I'm going to give a brief on the role of preeclampsia screening in the early part of the pregnancy in optimizing maternal health. Cases with the experience that we have had in handling these pregnancies. So preeclampsia generally affects around 2 to 5% of pregnant women, and it's one of the leading cause of maternal and perinatal morbidity. You have a very large number of women who and babies who die each year from this disorder. And yes, it is something that has to be addressed right at the root of the problem, which is at the early part of the gestation. The bigger concern about preeclampsia that is usually less addressed is that
What happened in the Chitrakala?
I think Sudarshan network is weak, I believe, madam.
There is network issue from sirs and I guess.
You can just ask him to. Sudarshan, I think your network is very slow. Why don't you close your video and start your talking? I mean.
Sure, ma'am.
Yeah, because your network is slow. You are getting freeze.
Okay, ma'am. I will just.
You can close your video so that you can.
Yes, madam. Yeah. You can see my slides now, ma'am.
Yes, sir.
Yes,
Yes,
I'm
sir.
sure. Yeah. So the current recommendations by FIGO is that we have to give a great attention to the link between maternal health and non-communicable diseases in the sustainable developmental goals. And this would include significant efforts to ensure that early screening for all pregnant women for the risk factors of these problems are done. So this was the.
Hello, Rekha.
This is the latest FIGO initiative on preeclampsia, a pragmatic guide for first trimester screening and prevention. And this guideline, which has come out recently, has got a wealth of information which we can use in our clinical practice. So they have defined gestational hypertension. I wouldn't want to go too much into that. It is based on the blood pressure reading and the absence of albuminuria. But a thing to note in the definition of preeclampsia is that in addition to the maternal organ dysfunction and proteinuria and gestational hypertension, blood pressure recording, presence of uteroplacental dysfunction is also considered as an organ dysfunction. That is, if you have a mother who is having a BP of 130/90 or 140/90, and there is also a fetal growth restriction in the baby with an abnormal umbilical artery Doppler waveform. So these are two factors that are involved. So in the absence of proteinuria also, they consider these patients as having preeclampsia because there is a maternal concern which has impacted the pregnancy, which is a fetus there. So in this regard, when you want to screen for preeclampsia, the most traditional method was using the risk factor based prediction. And this risk factor based prediction gives you a large number of maternal risk factors, namely the maternal age, the parity, all of which increase the risk of baseline risk of preeclampsia by around threefold. Women who have had a prior history of a pregnancy with a preeclampsia, short and long interpregnancy intervals, and ART pregnancies. ART pregnancies tend to have a double the risk of preeclampsia, especially more if there is a hyperestrogenic ovulation stimulation, or there is also some evidence that donor pregnancies tend to have an increased risk of preeclampsia, and obesities and other comorbid factors like pre-existing diabetes, lupus, which increase a baseline risk. So right at the outset, if we pull out all these risk factors from the mother, we have a solid number of information which helps us doing this baseline screen. But when you do this maternal characteristic based screening for preeclampsia, you get a mere prediction of only 40% of the cases. The remaining 60% cases of the preeclampsia remain undiagnosed by this risk factor based screening. And with this, you get a screen positive rate of around 10%. So around 10% of the women who walk into the OPD would have a risk factor based profile. And based on this, you might put them on blood thinning agents, namely aspirin, but you would miss that remaining 60% of the women who are destined to develop preeclampsia if we simply followed this risk factor based algorithm, and for which we need to introduce or include other factors. And these factors are other maternal demographic factors, the maternal blood pressure, the uterine Dopplers, and some blood markers. So I would just give a brief on each of them. With respect to the maternal blood pressure, we use the mean arterial pressure and not the systolic and diastolic blood pressure alone. And this is calculated by this method. The mean arterial pressure is calculated by this specific formula. And there is a very specific mechanism of checking the mean arterial pressure. You need to have the patient with the back supported with an adjustable chair and a table to keep the arm. And the best practice is to get the blood pressure measured in both arms simultaneously and 2 sets of readings 1 minute interval. This is the best practice recommendation. And the quality of evidence and the utility of mean arterial blood pressure is extremely strong. So if this is not feasible, you don't have 2 cuffs that you to measure it simultaneously. You measure the blood pressure in one arm and do it 2 recordings at 1 minute interval. The ideal is to make sure that you have factor based. It dramatically increases your risk prediction for preeclampsia to around 75% for a false positive rate of 10%. So when you start including the biochemical factors, the key biochemical factor here is the placental growth factor. The placental growth factor is an angiogenic factor. So in preeclampsia, you expect it to be reduced, and a MOM value of less than 0.7 for gestational age is what is considered as a significant value. When you look at PLGF alone as an isolated marker to predict preeclampsia, you find that the detection rate is close to 56%. So even if you have not taken any history, you simply do the placental growth factor and you see a low placental growth factor mom, then the detection rate for preeclampsia is around 55%. But we don't use it alone because we always combine all the factors. And when we combine them, it adds on to your prediction. When you look at the other biochemical factor, which is PAP-A or the pregnancy associated plasma protein A, this is again an insulin-like growth factor. So a lower level, less than 0.4 mom, is what is used as a cutoff for screening for aneuploidy. We use the same cutoff for preeclampsia screening also. And what does the evidence say? A low PAP-A mom is seen in around 8 to 20% of women only with preeclampsia. So as a single marker, it's not an accurate predictive test. So why am I reiterating this? Simply by picking up an aneuploidy screening report for the patient and you see a low PAP-A there, you can't think that, okay, this mother is at a very high risk of developing preeclampsia, or put them on a closer monitoring or a treatment protocol. So as an isolated marker, the placental growth factor is what performs much, much better than a PAP-A value. So the detection rate for PLGF we saw was 55%. For PAP-A alone, it's hardly 16%. Then you have the uterine Doppler. With respect to uterine Doppler, only message to take home is we take the average uterine Doppler, and a cutoff value for pregnancy is around 2.4. Anything above that is considered high. And again, as an isolated marker, around 48% detection rate for early preeclampsia. But what is key to note is it hardly predicts late preeclampsia, hardly only 25%. So when you look at an isolated marker, placental growth factor around 55%, your PAP-A hardly anything, your uterine Doppler gives you around 48%. So what the trial for utilization of aspirin to prevent preeclampsia did was to see if they could combine all these factors into one and achieve a significantly high prediction rate. And that study has shown that there is a significant detection rate for early preeclampsia. And that has prevention endorses that as part of the screening in the early pregnancy, you should add on the screening for preeclampsia also. So this is the algorithm that we look at. We have the maternal characteristics, the mean blood pressure, placental growth factor, the uterine Doppler, and the combined risk assessment gives you a screening. We use a cutoff of 1 in 100. If it's less than 1 in 100, it's screen low risk routine care. If it's more than equal to 1 in 100, screen high risk, and you start them on ecosprin or aspirin at 150 milligram dosage at night from 11 to 14 weeks.
Sudarshan? Chitrakala?
Buffering is on.
Yeah, its network is still not that stable. Oh, it's back again.
Sudarshan, you're not audible. We are not able to see you.
Sudarshan, we cannot hear you. Audio.
Yeah.
Can you hear me now?
Yes.
Yes.
I think your network is not stable again.
Yeah, I'm at workplace. Okay. So the in the screen positive cohort by the first stage screening using the maternal factors alone, if you have a screen positive cohort, then you can subject them to the second stage screening using the biochemical parameters. You can refer them to higher end and then consider additional modalities of management. So this contingent screening model also has been shown to have a far degree of prediction, and it can be used in low resource settings where you don't have the availability of a lab to do all these calculations. So when you look at multiple pregnancies, what are the pragmatic recommendation guidelines? If you put forth this multimodality screening for preeclampsia in twin pregnancies, you can achieve a detection rate of 99%. Almost all the preeclampsias can be predicted, detected. But you look at this second line, the screen positive rate is 3/4, which means if you do 4 patients of twins, you put forth the screening, 3 of them are going to be screen positives. So that's because the baseline risk factor for preeclampsia is high in twin pregnancy, and hence there is no need to do any screening test for preeclampsia based on all these factors in twin pregnancies. Because of the a prior high risk, you just start them on aspirin. When you look at the other pragmatic recommendation guidelines, it clearly says that other treatments like heparin, vitamins, folate, metformin, statins, none of them are based on credible evidence, and it's not justified or recommended. So I put forth this link for you. If you just see this link and click this link, it will lead you on to this FMF web page. This is what I said. If there is a lab setting that you have and they don't do the screening for preeclampsia, you can just get the absolute values of these parameters. And if you can just punch in all those parameters at your OPD setting, you will be able to get the calculated risk for preeclampsia. You have the history. You simply have to click yes or no. You can put in the date of birth, the height, weight, racial origin, the blood pressure, and the placental growth factor. If you do not have the biochemical parameters, that's what I said in the contingent screening. You can just say it's not available and use based on the blood pressure and the Dopplers and the ultrasound alone. And that gives you at least around a 75% risk prediction, as we have seen. So some form of screening is ideal. Ideal is doing everything. If it is not feasible in a low resource setting, you can use the risk factor algorithm at the OPD to do that. So once you have a report, how do you read that report? The report has got the patient details, and then it's got the pregnancy details or the risk factors. It's got the information. You can see that everything has been converted to MOM, even the mean arterial pressure, the uterine Doppler, everything has been converted. And then finally, you have the risk prediction for preeclampsia. Cutoff is 1 in 100. For this patient is 1 in 24. So let's go through some cases to see some take-home lesson. This was case 1. Risk factors that we can see, BMI is high. You can look at the blood parameters. PAPA is a little low. The placental growth factor is normal. 0.7 is the cutoff. And this gave a high risk for early preeclampsia of 1 in 67. And this patient was started on ecosprin. She also had a screen positive for Down syndrome. The karyotype was normal. At around 21 weeks, she developed hypertension. She was on medication. The urine albumin was nil. At around 37, 38 weeks, it was induced, and you had a 3.2 kg baby, which was delivered. This patient was on aspirin because of the screen positive for preeclampsia. Let's take the lessons after second case. Second case, lower maternal BMI. The placental growth factor was a little low. It was 0.59. PAPA is completely normal. Because of the low placental growth factor, the preeclampsia screen has increased from 1 in 177 to 1 in 24. And this was the growth curve of the baby. The baby was growing well at the 5th month, and the uterine Dopplers were also normal. And as I said earlier, the recommendation is that you start these patients on ecosprin. What does the evidence say? You need to treat around 38 women who are screen positive for preeclampsia to prevent one severe early preeclampsia. And this reduces the early delivery due to severe preeclampsia less than 32 weeks by close by this simple method of introducing this drug in the screen positive cohort. So this patient, as I said, was started on aspirin, and she developed blood pressure at around 38 weeks, and she was induced and delivered. So what did this pregnancy develop? She didn't develop early preeclampsia. She developed an increased blood pressure at around 37 to 38 weeks. So this is essentially a pregnancy which had a late onset preeclampsia. The growth was maintained. So what does this lesson say? Was there a shift in the disease from the earlier to the later gestation? That's what this evidence says. There is something called as an aspirin-related delay hypothesis. What aspirin does is it shifts the burden of the disease from your preterm severe early preeclampsia to your, either it prevents the disease completely or shifts the burden of the disease to your term or late preeclampsia. So what happens is that you're left with a group of patients whom you're able to imminently manage because the disease has come late in the pregnancy. And at that point of time, we have the option of doing an immediate delivery because that would reduce both the maternal morbidity and avoid the risk of a very significant premature baby. So that's third case. This was a woman who had a previous abortion and APLA was positive. She had a previous severe preeclampsia FGR. The mean uterine Doppler was high. The placental growth factor PAPA were both low. You can see that the screening risk showed a risk of 1 in 7. And this woman was started on ecosprin at mid-pregnancy. The blood pressure was high. And at around 28 weeks, the growth scan, the weight was around 17 centile. So in this scrub group was actually any form of screening required. What was noted was that in any group of patients who have a prior history of preeclampsia, the baseline risk factor in itself pushes you to put them on ecosprin. But what does screening do? Screening again helps you to triage two things. One, if the biochemical parameters are extremely low, it also is puts the pregnancies at a higher risk of early growth restriction and helps pushes us for a closer monitoring of fetal growth. Because this patient, the growth graph dropped in the 28 to 30 weeks, and that would have been achieved only because we have triaged them early. Case 4, this was a third gravida with 1 live child and 1 miscarriage, and the previous baby was around 2.5 kg. This was again a screen positive for early preeclampsia, 1 in 37. Again, this was because of the maternal age, the BMI, and the placental growth factor, all factors introduced into that. And the biochemical parameters were normal. At 28 weeks, you can see these growth graphs, which show stage 1 growth restriction, and pregnancy continued till around 36 weeks. At 36 weeks, there was a 1.8 kg baby delivered. Doppler was normal, and they would not have been started on aspirin otherwise, because both were completely normal. But by identifying the problem early, that is the baseline risk for preeclampsia being high, and starting the patient on ecosprin, what we have achieved is reduce the chances of this pregnancy developing severe early preeclampsia. And as a corollary, instead of having a very early growth restricted baby at around 28 to 32 weeks, we have ended up having a baby that is still small, but the pregnancy has achieved a gestational age of around 30.
Sudarshan, you're not audible. Sudarshan?
This was a woman who had a preeclampsia screen, which was significantly low risk, 1 in 1124. Because of the low preeclampsia screen risk, nothing was done. The growth was monitored. The growth was normal. The second trimester uterine Doppler was alone high, and nothing developed in this pregnancy. So this pregnancy, otherwise with the high resistance second trimester uterine Doppler, we would have been a little alarmed. But by the early screening with a very low risk and normal biochemical markers, we were able to reassure and tell the patient, or put the patient on a low risk triage through the pregnancy. And this was actually a well-developed baby at around 3.1 kg baby. So the screen positive cohort has got a higher incidence of SGA, and detection and treatment reduces that. And we'll have the last case here. This was again a pregnancy with a woman with a high BMI of around 30. The placental growth factor normal, PAPE alone was low, and the preterm preeclampsia screen was negative. It was 1 in 358. And the pregnancy was followed up, the screen positive for Down syndrome. NIPT was alone done. The preeclampsia screen was negative. No aspirin was started. But when you go back to that patient, when we went and punched these data, that is based on the maternal BMI and the ultrasound finding of Dopplers, and the previous history factors, the history-based screening actually gave us a high-risk screen for preeclampsia, which we might have put them on aspirin. But when we have gone through the combined risk algorithm, it actually given us a screen negative cohort. So what the evidence actually gives you is, when you do the traditional NICE or RCOG guideline-based algorithm, and there is a screen positive cohort, in these cohort, when you have put them through this multimodality screening and it is actually screen negative, then the outcomes are actually completely normal. You're not tending to miss out on anyone simply by ignoring the history. And this is the last case for our discussion today. This is again a woman with a higher BMI and a high resistance uterine Doppler in the early pregnancy. If you look at that, the PAPE is completely normal, 1, placental growth factor completely normal, 1.2, and the preterm preeclampsia screen risk is, yes, low risk, because it's only 1 in 264. And this pregnancy was not started on aspirin because the preeclampsia screen risk was low. At 20 weeks, the growth was normal. And if you can look at the growth graph, by around 31 weeks, the growth dropped dramatically. There was a severe early IUGR with a reversal of umbilical Doppler, which resulted in an emergency section. if you critically analyze this case, if we had gone back and looked at it, if we had based on the uterine Doppler being high, should we have started her on ecosprin? Would it have prevented all this problem? So what does the evidence say? The evidence very clearly states that when you have a pregnancy with a preeclampsia screen that is positive or negative, the whole goal of treatment is to reduce the burden of the maternal disease, and that as a corollary reduces the risk of the fetal disease. You don't tend to treat or reduce the burden of FGR in these non-preeclamptic women by starting aspirin. A very similar case which had a very similar problem where despite starting ecosprin, this mother did not develop preeclampsia, but there was very severe early growth restriction at 28 weeks. So what actually we do is when we do screening, we reduce the risk of maternal disease, and the risk of fetal disease is reduced only as a corollary. Any form of screening in the early pregnancy is not robust enough to detect or prevent early fetal growth restriction due to other placental pathologies also, which is why there is a significant subgroup what we see that even despite starting the aspirin or despite a preeclampsia screen being negative, despite the markers being completely normal, we do tend to see early growth restriction. So I stop my discussion at this point of time, and I thank the OGSSI team for having me share my experiences with them. Thank you.
Thank you, Sudarshan. That was really very informative. I was just going back to the time when we were students as postgraduates. We would rely on a mid-trimester fall in blood pressure and a dicrotic notch in the uterine artery, both of which today is history. And now we've come to the inverted pyramid of antenatal care, where we look at them very much early in pregnancy and look at the PLGF and all the values so that we can predict it. I think the most significant thing is that when you give the aspirin, it doesn't prevent late onset IUGR. It prevents early onset. But I think very significantly, even the little early onset is pushed and pushed so that it probably throws its ugly head a little later.
That's your aspirin delayed hypothesis.
Yeah,
that I put forth on my talk.
Absolutely. So the whether high risk or low risk, the question you had raised on one of your cases about whether you really needed to give aspirin for the SLE patient and APLA patient, not aspirin, whether you needed to screen.
To screen them.
Yeah, because she was out. Point well taken. I think it was very enjoyable to listen. Thank you very much.
Thank you, madam.
Thank you, madam. We will move on to the panel now. It gives me great pleasure to introduce Shanti ma'am. She will be the moderator for the panel on government programs towards safe motherhood. She's a consultant obstetrician gynecologist, is past president OGSSI, former director and superintendent, Institute of OBGYN, ISO KGH, and former HOD Kirpak Medical College. She is a very our beloved teacher, and she inspires and motivates all of us, and she's always available for us. OGSSI, when we think of anything, we think of a panel, we think of a talk, Shanti madam is always available for us. Ma'am, I request you to kindly take over, ma'am.
Thank you very much, Rajshri, for the very kind words. I would, already we are late, so I think we will proceed with our panel. So I have eminent panelists, so I'm really very glad about that. I have great pleasure in inviting Dr. Vijaya, our former director, IOG, and who's also the vice president of OGSSI, and she is now attached to Sri Balaji Medical College and a national level trainer for many government programs. Next, please. Next. It is nice to invite Dr. T.S. Meena, who looks after IOG now as Director FPC, and she is also master trainer for NCT screening program, and skill-based training in colposcopy and thermocoagulation. Next, please. I have great pleasure in inviting Sumati from KGH, who is the professor department, who is a professor in KGH attached to Madras Medical College. And the most important thing is she's actively involved in our maternal audits and especially trained in colposcopy. Next, please. And I have great pleasure in inviting Dr. Sumati, who's the HOD of Government Rajaji Hospital, Madurai. And she also is was the president of MOX in 2019-2020. Welcome, Sumati. So now I will screen. We know that safe motherhood is the ultimate goal of all OGSSI, and we have a lot of government programs towards that. And we also know that about the sustainable developmental goals, by which we have to reduce the global maternal mortality ratio to less than 70 per 1 lakh live births. So SDG 3 actually looks at it. And then it is also important that few states like Kerala now have achieved the very good, they have really decreased their maternal mortality. And as per record, it is 19. But then we understand that we have a long way to go, although we have decreased the maternal mortality. And as per SDG 3, no state in India also should have double the national average. That is very, very important. So it is not only few states. So as a country also we are supposed to see, and globally also we are supposed to look at other countries. So our MMR is 54, but then we have miles to go. And since we are only 5th in position in maternal mortality ratio. We have lot of government programs. RCH as a middle rung assistant, we used to religiously participate in all these things. Then we had this RMN and CHA, where adolescents even were looked after. Then came the NRHM, which has really made great inroads and has improved the maternal mortality ratio to a greater extent. Okay, so we have a 20-year-old primey with 8-week pregnancy. She has come to PHC for ANC. And the sister there registers her into the Pick Me program. So can somebody talk about Sumati? Can you take this question? Can you give us an idea about Pick Me? Sumati? Or anybody can take it? Hello?
No, yes.
Yeah, Sumati?
Sumati is there.
Yeah.
Yes, actually, it is a pregnancy and infant cohort monitoring evaluations, where it helps in monitors the mother's health and provide antenatal care, and also help to track the high risk mothers, because every entry is made about all the risk factors also. So this will help in tracking the high risk mothers also. And supposing this patient is going to another place in Pygmy, there can be a cross notification of this in the Pygmy port, so that the other person will take over and have an entry of it. So this is an important way of tracking the mothers throughout the state. So this is done in Tamil Nadu, where it is made mandatory, otherwise she will not get a birth certificate. So it is made mandatory that every mother should have a Pygmy portal entry. This can be made by the person itself. Self-registration is also possible, or they can have the help of the healthcare workers do it, or they can have it through the call centers. Whatever way they can have it registered. Once the Pygmy portal entry is made, there is an RCH ID which is got 12-digit thing that will help in the getting the birth certificate. So this helps in tracking the mothers. And almost it has helped in the antenatal mothers registrations. The number of antenatal mother registrations has gone up once this Pygmy has come, and we have increased in the number of the numbers of the pregnant mothers who have been entered. This has improved the quantity, and now this is going to be updated with more number of data being filled up with all the things. Then you can have a quality care also with this Pygmy. So this is the idea of having this.
Yeah, this was.
Ma'am, if I can add something. The Pygmy, actually, it is software is linked to both the civil registration system. That's why the birth certificate comes, and also the conditional cash incentive. So only when they register in the Pygmy, they are able to get their cash benefit.
Yeah, and so it is essentially a system of tracking the pregnancy, and even private, see, when all of them have to go to a center that is, they can register online, but then the nurse has to go through the records later, and then she just notes whether all pertinent investigations have been done. So that is also one double check system. So Pygmy has really helped us to track both the mothers as well as the baby. Okay. See, when we register the patient itself, we put the card, okay, MCP card, which is very, very important. But then, see, that itself gives us an idea about all the advices which should be given. So that is really very good. But is there any other IEC material where which can be given to the pregnant woman?
There is a MySafe Motherhood booklet for the expecting mothers, which is put forth by the Ministry of Health. But in our card itself, we have all these, the importance of antenatal checkup, when she should take her iron and folic acid, the danger signs of pregnancy, and the importance of institutional delivery and breastfeeding, family planning. All that is given in that card itself. And of course, the booklet is more explanatory, and it's all with pictures. So even if they can't read, they can see all that in the book.
So that is there. So we are supposed to give all these things. That is very, very important. And any financial assistance offered to help her take nutritious diet. We know that only if she is healthy, then she can have a good outcome. So what does government do for that?
Ma'am, the Tamil Nadu government has got the Muthulakshmi Reddy maternity benefit scheme, which was started way back in '87, but slowly, gradually it has increased, and now to the present size where the funds are 18,000, and it's mainly for better medical nutritional facility and to partially compensate for the income loss. And it's given for all the pregnant women who are residents of Tamil Nadu and below the poverty line, and it's at different intervals. Of course, migrant mothers are also given, but they're given only 2 installments, and the nutrition kits. So it is in 5 installments.
Yeah.
And
so can you elaborate on that, Meena?
Yes, ma'am. As I already told you, the first installment is as soon as she registers that is before on or before 12 weeks, where she'll be given a monetary benefit of 2,000 and also a kit, which that is for all her protein, all these health mix and all that is given. That is worth another 2,000. And the second installment is at the end of the 4th month, again another 2,000 rupees with another kind benefit. And the third installment is after delivery. It should be an institutional delivery, and it should be after completion of all the no, it's after the delivery. It is 4,000, ma'am. And the fourth installment is after the immunization, the initial immunization of OPV, the Rota, Penta. There it's another financial installment of 4,000. And of course, the fifth is when the baby gets the MMR vaccine. That is around 9 to 12 months. So totally it is 18,000 is the financial assistance which we are giving to the mothers.
Can I add on that, madam?
Yes, Vijaya.
Yeah, she should have been either temporary contraceptive, or if she is 2 and above, she should be permanently sterilized. Only in that condition, the 5th installment will be given.
Higher order births they get only the 1st and the 5th installment and the nutrition kits.
Yeah.
But it's only for 2 deliveries that we are giving the entire 5 installments.
Yeah. So that all these have been clearly explained. And can you also tell me what is there in the Tamil Nadu Amma maternity nutrition kits?
They have an health mix powder, which is 2 packets, 500 grams, and an iron folic acid syrup, and dates, and there is a albendazole deworming tablet and ghee. Initially, they had the protein biscuits. I think that has been taken out.
Yeah.
And for the child,
ghee and 1 cotton towel. So these are the things which are available. And what about, now we know in Tamil Nadu, this is a modified Muthulakshmi benefits, maternity benefit scheme. Initially it was 12,000. Now the value is 18,000. And what about cash transfer to pregnant women in other states? Any contribution from the center?
The Pradhan Mantri Matru Vandana Yojana is the direct benefit transfer, where they give 5,000 in 3 installments, and for the first child, and the second child, if it's a girl, it is 6,000. And of course, again, it should be registered 150 days. The first 150 days, you get the first installment of 1,000, then 180 days, another 2,000. And after delivery, they get the 2,000 again. It's actually 60-40 sharing between the central government and the state government. And for us in Tamil Nadu, it has been co-branded with our Muthulakshmi Reddy scheme, where they say the 1, 2, and 4 will be from the central government thing, and the 3 and 5 will be the Muthulakshmi Reddy benefit scheme.
Yeah, this really benefits pregnant women from states which are, with the low performing states. So there, in many of the states, they do not have this cash benefit. So the central government scheme really helps.
I think Telangana has a benefit scheme like us.
Yeah. This patient at 14 weeks is a woman, pregnant woman, not a patient. Her brother-in-law, she lives in a joint family. Her brother-in-law's son developed chickenpox. So she's really, the lesions were noted around 9 p.m. and she wanted to know what she should do, because her mother-in-law was really very worried. So where can she get the necessary information?
Health information can be got by dialing 104.
I think, can you mute the background noise?
Chitrakala.
கேளுங்க, நம்ம வாங்கிட்டாங்க. பண்டையே கொடுத்துட்டாங்க.
Suganti, I think you have to mute Suganti. Suganti.
Suganti.
Can get the information from 104 medical helpline, ma'am. by getting all the helpline 104 will help us in getting the help.
Yeah, that
whatever
really is
medical
very active. A beehive of activity. If we go and see that, and those people working there are quite knowledgeable, and they do whatever is necessary to help the patient out. Okay. So what about ANC and diagnostics in remote areas? See, Tamil Nadu, no problem at all. But there are certain areas where they do not have OGSSIs, they do not have sonologists, because a first trimester screening for Down syndrome is very important, but they might not have qualified radiologists or sonologists. So in that event, what can we do to improve the pregnancy outcome?
Good evening, madam. That is PM SMA scheme, madam. That is the Pradhan Mantri Surakshit Matritva Avoidance Scheme. And in this scheme, actually, the main objective is it engaged mainly to improve the quality and coverage of the antenatal care, that is including diagnostic, counseling services, as already have told, which may be very difficult if it is not available in the remote area. But it is also the private sector is also approached, and systematic approach has been planned. So also from our physician, sonologist, as well as the all facilities will be made available in a center where all the women will be pooled. That is mainly on the 9th of every month. So that all applicable diagnostic services and screening and also appropriate management of any existing clinical condition, that is anemia, as well as the PIH, as well as gestational diabetes, and also appropriate counseling services also made available for them, and proper documentation also, and additional service opportunity also will be there if they missed any antenatal visit. Mainly the high risk pregnancies will be line listed if this on this day, so that all the high risk women will be line listed, very easy to follow the people, follow them also. So this main principle is it is a single window system, and it has got a national portal also, madam. So whenever you finish it, it will be entered also. It has got a national portal also, and physician also from private sector, they mainly encourage to provide the voluntary services at public health facilities. So it's a cooperation between the government as well as the private sector, so that they are also making the safe motherhood booklets will be available, and also the awards will be distributed during this high risk day, that visit during the visit. Oh, they will be having a sticker, ma'am, that green sticker for women with no risk, and there will be a red sticker given to them that indicates they will be having a high risk pregnancy. And all the contributions they are advised to celebrate the individual achievers award is also has been given in this scheme.
So essentially, it is done to assure comprehensive and quality antenatal care free of cost. Just because they are in certain areas where certain facilities are not available, they will not be denied of advances in medicine also. So actually, our Prime Minister gave a request to medical fraternity, and many of the FOXI members do it even in their clinic free of cost every 9th of every month. So that is also there. But this is a good example of public-private partnership. So what about mentorship?
Can we add on one thing, ma'am?
Yeah, please do.
Madam, this PM SMA is now asked to be conducted again on 24th of every month, because once you identify a risky mother, you cannot stop with that. They can come back again on 24th. So they have again it's checking up again on 24th. Now they have started on 24th also, so that the high risk mother to have a follow up again, not wait till the next month. They can come in
2
between.
weeks.
So 24th.
All these things. So what about mentorship now? So much mentoring is done in the government system. So kindly enlighten on that.
Ma'am, each of us have been given zones, like in Chennai district, we have the Chennai Corporation zones. So every hospital has 6 to 7 zones with them, where we have a real mentor who are the assistant professors who will be talking with the ground level, the staff, and you have a virtual mentor who will be the professor in charge. So any high risk case in that month, if they have the EDD, they will be sending the list to the mentor and they will be following up what they're going to do, what is the birth plan, all that will be discussed with the mentor, what is the progress, and if they have to see the patient, if they need any help in diagnostic or the planning of pregnancy, they even ask to see the patient at the referral center.
So that mentorship is really very good. And in certain districts, we have a very nice comprehensive WhatsApp system, which includes the private doctors too. So it's very important that to note that 1/3 of deliveries still occur in Tamil Nadu in private. So even they are also involved, and because of any mentorship can be done to all the people who cater to the pregnant women. So the outcome will be good. Any schemes to promote institutional deliveries?
Madam, it is Janani Suraksha Yojana. That is mainly to promote the institutional delivery, and depends upon the states. They have divided into low performing states as well as with a good high performance. So this Madhya Pradesh, Uttarakhand, like other, they have selected accordingly. There will be eligibility criteria and also the cash assistance. So usually in our state, we take it as in the urban it is 600 and rural it has been given as 700, and it is mainly to promote the institutional delivery. So where there is a low performance, increasing the amount, that is about 1,400 and also 1,000 in case of urban area, to mainly to promote this institutional delivery so that maternal and neonatal mortality will be reduced. It is for delivery up to the second child, madam, and the third child is only if it is low performance status only.
Yeah, so only in the areas where we have high mortality. Actually, they need contraception, but we don't want the mothers to die. So because of that, in low performing state, even third pregnancy is being given money to promote institutional delivery. So we know that we talk about lot of delays which promote increase the maternal mortality. And one thing is the quality of service in the first first place where they go for delivery. So because of that, we have lot of BMONG centers and CMONG centers. So can somebody elaborate on that? So the main thing is, see, even in additional PHCs, although they don't conduct deliveries, they are supposed to have all these things. All these have been converted to BMONG centers where IV fluids, antibiotics, anticonvulsants, because we understand that hypertensive disorders of pregnancy are the second commonest cause and of maternal mortality. And of course, we have the comprehensive emergency obstetric care unit where C-section, emergency newborn care, everything can be done. So we have about 129 CMONG centers and 644 BMONG centers in Tamil Nadu. Okay. So patient has developed labor pains. So husband has gone to work. So is she going to the hospital?
Ma'am, as you already told, the delay, one of the delays is delay in accessing the healthcare facility. So to tackle this, we have the 108, which is a toll-free number, can be dialed from any phone, either a landline or a cell phone. And they usually it goes to the emergency response center, where the nature of the complaint, nature of the response and the location is given. So immediately within 20 minutes, the ambulance reaches and there is an EMT, that is the emergency response technician, medical technician is there in the 108.
Yeah.
And actually the EMRI and the TNHSRP, it's a private public partnership, and in fact, they have given a login ID to the Pick Me also, so they can see who are the EDD of the mothers, and they can even dial the phone numbers and ask them if they want any accessibility, if they have any problems in accessing the hospital. Even for antenatal care, we have the 102, which will take them for antenatal checkups also.
Yeah. So we have really good system. This 108 technicians, EMT technicians are quite knowledgeable. They have been trained very well. So initial help can be rendered by them in emergencies. And 102 is just for transport. So what measures, we understand that good antenatal checkup is very important for outcome, but a good intrapartum care is also very, very essential. This is rather crucial. So what measures help in good intrapartum care?
Skilled birth attendance is very important, and it's a component of safe motherhood. So the Lakshya has been started.
Can you mute yourself, Suganti?
Can somebody mute her? Yeah. So Lakshya is a labor room quality improvement initiative, which improves the quality of care in the labor room and the maternity OT, so that the pregnant woman has respectful and quality care during delivery and in the immediate postpartum period, thereby reducing the preventable maternal and newborn morbidity and mortality. And the other program is the Suman, that is the Surakshit Matritva Ashwasan. So that is to provide a positive birthing experience to the mother and the child. So that will assure dignified, respectful, quality healthcare at no cost. And there is a zero tolerance for any denial of services for any pregnant woman. Yeah. And of course, FOXI has started the Manyata, that is a nationwide initiative which is improve quality of maternal and neonatal care in the private sectors. So all these programs are there to improve the intrapartum care, thereby going in for safe motherhood.
Yeah. So once they are Lakshya certified, then quality care is very much possible in a methodical way, right from the 4th grade servants up to the head of the institution. So that is very much needed. And of course, you have nicely talked about our FOXI sponsored Manyata program. So in Tamil Nadu, we have 50 Lakshya certified centers. So we hope that we get more such centers. So here also, I think mentoring plays a great role. Especially one of my former postgraduate was posted in a hill station. So when they have certain emergencies, they really, the mentors really have helped them a great deal, and in helping them to manage the cases appropriately. So any safe delivery app?
There is a safe delivery app, which is a smartphone application, which provides the skill birth attendants with direct and instant access to the evidence-based and up-to-date clinical guidelines for BMONC, ma'am. So it supports their everyday work, and it's easy to understand. It has animated instruction videos, action cards, drug lists, and so it has different modules which will address the different problems they can face. And it has been started with the collaboration with the Ministry of Health and Family Welfare, JAPIGO, the Maternity Foundation, and of course the MSD Mothers and Bill Gates Foundation also.
And also the e-Sanjeevani, where the patient can directly call us, and every week on a particular time of the day, 2 obstetric consultants will be answering their queries. They don't have to come all the way to the hospitals. That e-Sanjeevani is really helps us in that way.
Yeah, the safe delivery app in certain states in the north. I mean, this has been actually translated into Hindi also, it is available. And they are really doing well there in certain things. It has really helped them to help our pregnant women. So now mother has been looked after very well and she has been gifted with a healthy newborn. Any special gifts for the newborn?
Ma'am, we have the Amma baby care kit. As we say, Padinarum pet resort. It has 16 items like a bed, the mattress, a mosquito net, dress, towel, napkin, shampoo, and soap with a soap box, oil, and nail cutter, rattle, and a toy for the baby. Hand wash for the mother every time she handles the baby, and soap for the mother too. And there is a Saubhagya Sundar lady, and of course the kit bag.
Okay, the kit bag itself looks very inviting.
Yes.
So now this is the WhatsApp which is coming for the past few, traveling like fire the past 2 days. So this says that India, actually the population is predicted to overtake China's in mid-2023. And people say it has already overtaken. So we understand there is an unmet need for family planning. And this will, if it is covered, it will reduce maternal deaths by 2/3. So how do we go about it? Because this is very, very important. Having less children. Earlier we said he too, ours too. Now it is one person, one child now, which we are propagating. So how to really go about it?
Good evening, ma'am. This postpartum IUCD has really taken up in a very, very good way the entire Tamil Nadu, and almost all the government institutions have 100% coverage of the postpartum IUCD, and the patient is also given 300 rupees if they have given consent and they've got inserted the copper T. And if they are going in for a permanent sterilization, if they are below poverty line, they are getting 600 rupees plus 150 rupees motivational fees. And if they are above poverty line, 450 rupees. Whereas for vasectomy, they are giving 1,100 rupees because male are not very inclined to undergo permanent sterilization. The government has raised the incentive to 1,100 rupees. Having said that, we should also think about the adverse complications of permanent sterilization. Suppose if the mother dies following a sterilization, they will be given 4 lakhs rupees as a compensation if they die within 7 days. But this is not the appropriate platform to talk about the mortality.
I think we will concentrate more on methods which really improve. Okay,
yes,
so
yes,
this can happen to anybody, anywhere. But then what I want you all to notice, I really thought that post-placental IUD has taken off very well. But I mean, in 2011 or 12, Gilpop Medical College topped the national statistics for post-placental IUD. But then now, although we think we are putting a lot of post-placental IUDs, NFHS 5 says that national average is only 2.1%. And also when we talk to our people in PHCs, medical officers, nurses, ANMs, they talk a lot about Antara uptake. They say patients are very happy with that. But NFHS 5 says it is only 0.6%. So as OGSSians, to reduce maternal deaths, it is very important for us to really talk a lot about contraception in the antenatal period itself, get their signature, and then do the appropriate coverage postnatally or at least in the ureperiod. So that is very, very important. So what about this JSSK? So they are randomly picked up. They are all.
Yes, madam. Janani Sishu Suraksha Karyagram. It is mainly to improve the maternal and child health care. And whenever any woman, that is a pregnant woman, delivering in the public health facilities, it is mainly guaranteeing zero expense deliveries and also zero expenditure treatment for sick newborns. and mainly free drugs and free consumables and free diet up to 3 days of their stay if it is a normal delivery, and for cesarean section 7 days. And also mainly the transport, the initiative that is providing a free transport from a home to institution, and also from any referral center, and also drop back home. And it is also highly successful, and so many, the percentage accepting this drop back home, they are also increasing, madam, now.
Yeah.
But mainly, yes.
Yeah, please tell. Continue.
Yes, madam. Also, all these blood transfusion and all diagnostics also will come under this scheme.
Yeah.
So it's
really very helpful, and it's extended to the baby for 1 year. So what is the outcome of JSY and JSSI? So because of all these things is where the institutional deliveries have increased. In Tamil Nadu, they've already always focused on institutional deliveries. As per NFHS5, the national average is 88.6%, but it is 99.6% institutional deliveries in Tamil Nadu. So we know that always when we talk about maternal death, anemia seems to be the compounding factor. We have lot of programs from 1970 up to now, but somehow we are not able to make an indent into the prevalence of anemia. Even now, 50% of our pregnant women are anemic, and 58% of our breastfeeding mothers are anemic. So this is also there in Tamil Nadu. So what is Anemia Mukt Bharat?
Madam, this is a very, very popular and successful program. It is commenced by the Minister of Health and Family Welfare in 2018. You can easily remember by 666. They have 6 into 6 into 6 strategy. The 6 is focusing on mainly girls and also young women and reproductive pregnancy and lactating women. The another 6 is how we are going to treat the anemia by giving albendazole deworming and iron and folic acid tablet fortification. Very, very important of double fortification of salt with iron that is followed. And also we have to follow the scheme round the clock about the solid body and smart mind. That is the term they use. When you have a solid body, your mind, the intelligence and your education also improves. And you have to test the hemoglobin by digital hemoglobinometer. This is a point of care method. And another one is there should be a coordination between all the ministries, because it involves a lot of strategies, protocols and planning. And they have a dashboard and a digital portal for entering the anemic mothers and everything. And this is really taken up in a good way, ma'am.
Yeah. And as OGSSIans, we have to do delayed cord clamping.
Yes,
that will prevent anemia in the newborn, and that newborn will later become a mother. Okay. Yes, so small interventions. I think government is doing a lot, but then we have to extend our helping hands and be really proactive. Are there any programs for children and adolescents? We understand that an anemic, healthy adolescent will become a healthy young adult and a healthy mother. Okay. But then if that adolescent is sick, maybe she has anemia, she has cardiac disease like that. So how to really prevent all these?
Madam, there are RBSK and another is RKSK. This Rashtriya Kishore Swasthya Karyakram, that mainly it is focusing on the adolescents, that is between 10 to 19 years. And it has got 6 strategies, mainly focusing on nutrition, sexual and reproductive health, and also substance misuse and the gender-based violence, as well as sexual and reproductive health, and also some awareness about the non-communicable diseases. Here they are having a successful, that is, they will select peer educators from the Panchayat Union and they will be educating them. And also they will be having once in 3 months, they will have this Adolescent Health Day celebration, and they will be giving awards and prizes to the participants. And also mainly menstrual hygiene for the girls. They are mainly focusing and supplying the sanitary napkins, and also focusing on iron and folic acid supplements to all. That is on Thursdays, they will be giving this iron and folic acid supplement. And these peer educators, they are becoming more successful now. And also substance abuse. Now it is on the rise. So it is also, they are focusing on that substance abuse as well as gender-based violence, as well as sexual and reproductive health also. This adolescent health clinic also. It is adolescent health friendly clinic is also being there in all the hospitals, and so that it is more useful for all the adolescents to become aware about the consequences of the all things. And another is Rashtriya Kishore, another is RBSK. Here it is very successfully being done, followed in all the districts and being reviewed by the collector also frequently. And they mainly reduction of any birth defects or disease or any deficiencies has been done at the root level. That is at the village level itself. They are identifying any birth defects and any diseases. They are referring to the DIC, that is the District Early Intervention Center. And this network is working in a fine way, that even with cleft lip, cleft palate, how many babies are there in that area? All VHS and block medical officers should know about it. And what is the plan? When they are going to do it, whether it has been done on date, whether there is a delay, and also heart disease, and also refractive errors. They are visiting the school once annually. They will be visiting the school. They have to cover all the school children in their area. So they are identifying all these, and even this heart disease. They are Apollo has got a collaboration MOU, so they can refer the patient to the Apollo hospitals. Even Chennai, they are coming from Madurai to get treated. So it is a regular follow-up. And so they will be having when to do for this patient if they booked it, and if it is very late, getting delayed, the collector will be intervening in this, and they will be getting the child will be looked after earlier also. So it is very successful, and both has been done in a successful way, man.
Yeah, because we understand that heart disease is the third common cause of death for in Tamil Nadu. For MMR. So this RBSK medical officers need to really do good work, and I think they are actually expected to see for 21 problems. So all these things, if they are found out quite early and treated effectively, then we will have healthy citizens who will be healthy mothers too. And it is nice to hear from Sumati, who is an RKSK national trainer. So is there any program that prevents fetal infection?
Madam, this is covered under UIP, madam, MMR vaccine. So the coverage of the kids, that has to be confirmed. So this is given at 12 to 15, and then it is at 4 to 6 years. And so if it is the full immunization coverage, after that only this they will be receiving the amount also. Muthalakshmi Reddy scheme is also fully sanctioned after coverage of the immunization. Yeah, so this rubella has got an important role, because if they are not get immunized, there is more chances of the infection, and it has got a perinatal mortality, morbidity, everything is more. So this vaccination has to be covered, and it has to be followed strictly.
Yeah. So now lot of stress on this. We do not want rubella anymore to affect a pregnant woman. So this Muthalakshmi Reddy scheme, the last installment is given after the first MMR vaccine. So that is very, very important. And now actually pediatricians are talking a lot about the inclusion of varicella vaccine also in the immunization scheme. That is not there so far. Only in private they have, because mothers and both babies can get affected, which can lead to adverse outcome. Okay. So we know that hypothyroidism, they say now is about 11%. So many, that is the Indian studies quote that. So what is this program which helps to prevent this to a certain extent?
This National Iodine Deficiency Disease Program, mainly it is focusing on the supply of the iodized salt. And also we are, because the adverse effect, if the woman is a hypothyroid becoming pregnant, there is more chance of miscarriage as well as the stillbirths. And if the baby is born to the hypothyroid mother, it may be a written also mental disability may be there and mental retardation. So the sequences or the consequences of a hypothyroidism is also having an impact on the social life of the newborn baby. So it is mainly now we are doing a thyroid screening also, madam. So this mainly iodized salt is supplied and they have to follow that strictly. And screening also has been done for all the pregnant women for hypothyroidism in the first visit or second visit itself. We are doing it, and also they are having, if known hypothyroid, strictly we have to maintain the hormone level within the range for each first trimester, second and third.
So a few cases of hypothyroidism can be due to iodine deficiency, although thyroxine synthesis needs iodine. So the focus because there was a paper, my PhD dissertation, which was submitted 2 days ago, where it was noted that private pregnant women from private areas, they do not take iodized salt at all. They talk more about that Hindu rock salt, all that which do not contains iodated salt. So that is very, very important. And of course, I think we have to be proud of world's largest healthcare program, Pradhan Mantri Jan Arogya Yojana Ayushman Bharat. So anywhere, this is the insurance scheme by the center for people below poverty line, and they can take treatment, even very fine treatment, very advanced treatment can be taken in any hospital. Okay, so UNFPA World Population Report 2022 says that 8 women die from causes related to unsafe abortion each day in India. This seemed to be very shocking. So what is the solution? Because we, MTP Act is the first, India was the first country to enact such good liberalized MTP Act. And we have had frequent amendments also, where they have been pro-women. Okay, but then why is this still so?
This newer MTP Act has liberalized so much, even unmarried women can approach for a medical termination of pregnancy. And also they have raised the gestational age up to 20 weeks. And between 20 and 24 weeks, there are certain special categories like pregnancy because of rape or because of other vulnerable disease like a mentally, differently able person, minors, and incest relationship. All those people can come for termination of pregnancy between 20 and 24 weeks of pregnancy. Beyond 26 weeks, definitely they have to go to the medical boards. That is only for anomalies. It is not due to rape or any, up to rape is only up to 24 weeks. Beyond 24 weeks, it's only because of anomaly. The medical board is formed in each, every city, so that we can refer them to the medical board, which consists of sonologist, gynecologist, and psychologist, ma'am.
Yeah, psychiatrist as well as a pediatrician. Okay, so I think a lot of acts are pro-women, women-centric, and I think as healthcare providers, we should be knowledgeable about that. Can Sumati tell us about maternal death audit and near-miss audit? That is Tamil Nadu has been doing this for long, okay? So that we learn from our mistakes and do not repeat it again and again. We understand that many cases of maternal mortality are preventable. So how do we go about it, Sumati?
Actually, the maternal death audit, it is a maternal death review. Usually people think it is maternal death audit and they are hiding facts, and so many things are happening, fearing for questioners and other things. It's a maternal death review which is happening in Tamil Nadu actually. Actually, it happens in the district, it happens in the facility, and in the community when it happens, it is called as a verbal autopsy, or it is a community-based death act. Number two is when it is happening in the facility, it is facility-based death audit, where you collect information from the institute and it is conducted in the institute. It is facility based. So this community based is basically with the family members, patients, persons who are there in the community, and it is guided or it is done by the base block medical officer at the primary care level. Whereas in the facility, it is the institution and it audits. When it comes to the state audit, it is always a comprehensive, where collective audit is done through video conferencing, where you have the people from the public health, people that includes both the public health person as well as the secondary care people, and also in the medical college institutions, including the private institutions. So collectively, you have a comprehensive audit of all the state, and this is happening every month. Collection and data collection. First important thing about this maternal death is first information has to be given within 24 hours wherever the death has happened. If it is in the rural area, they have to inform it to the block medical officer. In the institution, they have to inform to the state nodal officer. Within 24 hours, first information report is done, and after that the person should conduct the audit, and then they have to give the case sheets for further auditing to the state audit, and then it is audited. So it is not actually audit, it is a review where we find out what is the cause, where is the lacunae at the primary care level or at the secondary care level or at the tertiary care level, how well you can perform from the place of it is just identifying the missed opportunities as well as improving the system, whether it is a fault of the system, whether there is any fault at the personnel. So it helps in the system empowerment as well as it helps in the personnel. If it is there, we can give training to the person. So it is a comprehensive way of collection and finding out what is the cause for the maternal death.
Yeah.
So this is what is happening in this.
Yeah, but we know
and
that for
miss,
every one maternal death, there are a lot of near misses where the woman really suffers a lot.
20, we will have 20 members who are suffering. That is the proportionate things. So if you really reduce the maternal deaths, then you can go for the near misses to find out what is the cause for it. So looking at when it is near miss, it is a person who almost nearly dies but escapes from the death. So you have a criteria which has been fixed up by the WHO and it has been modified by the NHM also. You have a booklet of it and what are the criteria for near miss depending on the hemorrhage, hypertension, all these things. And then if a person is having a near miss, from those also we can learn the lessons, what is the reason for this, and we can empower so that we prevent maternal death. So this is complementary and people will not hide facts. Actually, when near miss is a success story. So they will come out with a success story and will tell us what has really happened. And the survival mother is also there to tell what has happened and what are the good things which has been done in the system. So that way it helps us in helping or preventing the maternal deaths.
So auditing our own, actions is very, very important. It is not to find fault, but to find out the lacunae and correct ourselves, not only ourselves, the system too. And maternal near miss audit really helps also in rectification of potential problems. Okay, so we understand that there are many welfare schemes for better health of pregnant women and optimal outcome for mother and baby. Vital for OGSSians to know about them and educate the pregnant women. And healthcare delivered as life cycle approach will pay dividends by making a woman contemplating pregnancy healthy. Now, I really thank all my eminent panelists for their excellent contribution. I would like each of them to say one carry-home message, all four of you. Short one. Which scheme, something, so that we have to remember.
We should become first, madam, in reducing the maternal mortality in India. We should somehow beat Kerala.
See, we are fifth, Vijaya. From second position, we slip
we have
down
pushed.
and down. I think we have to be more methodical, train our people. That is very, very important. I think, and we should have some goal in our minds.
Yes, ma'am. So much of government programs. Yeah, ma'am. We have to.
Yeah, I think it is as medical officers and healthcare personnel, it is our duty to know about all these things and implement them to have a good outcome. Okay. Others? Nicely said, Vijaya.
One thing which I want to say is this maternal death audit is not auditing, it is only reviewing. And none of the persons have been penalized for the mistakes which have been done. So if there are mistakes, kindly admit it so that others will not commit. Because when we read our Ian Donald book, he will have written for all those who commit mistakes as I have made. So that is the statement which he had given, telling all the mistakes which he has committed in a book. So we are not bold enough to accept our mistakes. So that's the problem. We'll have to be bold enough to accept our mistake, provided it is not gross negligence, which we should not have as professionals. As doctors, we are not supposed to have it. And if without in that aspect, you can just admit what is the fault. That is not a problem. When you admit it, the persons will also, other persons will learn from it. So that is the point which we have to make it up. And should not be scared when somebody is criticizing. It's only a healthy criticism which you have to accept it.
And I mean, the loss has been very costly also. That we should understand for the mother. So it is just as Sumati nicely put it, it is a review so that we correct the mistakes which have happened or try to correct whatever things can be corrected later so that we have good outcome for others too.
Ma'am, one take-home message will be safe motherhood just doesn't start with the pregnant woman. It starts from the childhood. As we said, all the programs to the adolescent, anemia should be corrected, reproductive tract infections, all these, as well as antenatal care, intrapartum care. And of course, you have to follow it up with the family planning. And all our training also comes as part of the Safe Motherhood program. So we have excellent FRUs, first referral units, and we're training all these doctors. The medical officers are being trained in skill birth, SBA training, all that they come for training to the medical colleges. So that also helps a lot in putting all these programs.
Sumati, thank you.
Yes, ma'am. Yes. Respectful maternity care to be kept, madam. It has to be sustained. That's the only thing.
Yeah.
Thank you, Oxy, for the opportunity.
Yeah, yeah. So I really thank Rashtriya Chairman Safe Motherhood Committee, our team Oxy headed ably by Jayarani and supported by Kundavi and her team for giving us an opportunity. And I thank all our eminent panelists who have really made this panel productive one. Thank you.
Ma'am, we thank you on behalf of the panelists. We thank you, ma'am, for this wonderful panel. We were all scared what you'll be asking. It felt like a smooth flow. Nice it was, ma'am.
I think we learned.
Thank you, Shanti ma'am. It was amazing. It was really wonderful, and you had covered almost many things which we were not aware. As a private practitioners, we were not aware, and it's really good that you put so many things to all of us to know about it. Thank you. Thank you.
Thank you. Thank you, Shanti ma'am. Thank you, Meena ma'am. Thank you.
Thank you. Thank you, Oxy.
Really excellent panel. We've learned a lot. I will now request Kalaivani,
yes, ma'am,
Treasurer Oxy, and my dear friend, she's the Director ISO KGH, for the vote of thanks, to deliver the vote of thanks.
Okay. On behalf of Oxy, I like to, it's a great honor and privilege to propose a vote of thanks for this wonderful seminar towards safe motherhood. I like to thank our President and the Secretary, Dr. Jayarani Kamraj and Dr. Kundavi for organizing this wonderful program. I like to thank Dr. Preeti Kumar, Chairperson, Foxy Safe Motherhood Committee, for being the guest of honor. And I'd like to thank all the three speakers, our chief guest, Dr. V.P. Paili, past President, Kerala Foundation, and who gave a wonderful lecture on trends in maternal mortality and measures to bring it down. As we all know, Kerala is a leading state in bringing down maternal mortality. And the way he put it, we do have learned all the measures to how to bring it down. I like to thank Dr. Sunita Tandulwadkar for her speech on FGR. I like to thank Dr. Sudarshan for pre-eclampsia screening. We all know as first trimester screening, pre-eclampsia screening is also closely being followed, and it is being done in almost all the centers. I like to thank our chairpersons, Dr. Sangeeta Menon and Dr. Premila Menon, who consented to be the chairpersons for these sessions. And finally, I like to thank the wonderful panel moderated by Dr. Shanti Gunasingh. Madam has covered almost all the programs in the government setup and what are we doing in the government setup. Almost all the programs like JSSK, JSSY, PMJY, RKSK, and recent screening on thyroid has been covered, and all the questions have also been answered in the panel. And the concluding remarks given by all the panelists, Dr. Vijaya, Dr. Meena, Dr. Sumati, and N. Sumati and C. Sumati. And what Sumati has said, it is not an audit, it is a review, but still people have their own concern about it. And this review have really made the maternal mortality in Tamil Nadu, and we have really brought out to a great extent because of all these review. And I finally thank Shield for sponsoring this wonderful program. And I also thank the participants who have tuned for this program and who have stayed almost till night. So I thank one and all. Good night.
Yeah, Rashri also as chairperson.
Yeah,
Motherhood Committee.
Yes, Rashri, yeah.
Really have taken so much pains, and I think a Safe Motherhood Committee is leading among all committees in all the meetings. I think they are doing
Making it late in 9:30.
No, not as my friend, but really Safe Motherhood Committee had done so many programs really in this past month. Thank you, Raji.
Madam, it goes to you.